Good morning, everybody. Welcome, Bwrdd, croeso. Welcome to our board meeting. I'd also like to say a special welcome to our reverse mentors for the board, and they are observing today, and that's Callum Wilson, Rhys Kent, Isabella Ionides, and Tracy Stevens. So a warm welcome, and I hope you enjoy the board meeting. As it is Carers' Rights Day today, we're going to start our board meeting with a small clip in relation to carers' rights. Thank you.
Hello, my name is Anne Wen and I am a carer for my teenage daughter. She was diagnosed with Asperger's syndrome last year, which is a subset of autistic spectrum disorder, and has mental health difficulties. I work for Hywel Dda University Health Board. I support her in all aspects of everyday life, from when she wakes up to trying to get her settled to sleep at night. This can impact on my working life a great deal. It may mean that I am unexpectedly late to work if she has a bad morning and is refusing to go to school due to anxiety, that I get a phone call from school during work to go and collect her, or that I need time off during the working day to attend meetings about her care or education. During times of her self-harming and suicide attempts, I was unable to work at all through my own stress and anxiety, and needing to support her 24/7. Having the support of a sympathetic line manager makes such a big difference to the levels of stress associated with my caring role. Through the use of the new Carers Passport available to Hywel Dda staff, I have clear approval for flexible working hours, time off for appointments, and the ability to work from home at short notice. Knowing that I will not be reprimanded for being late, missing a meeting, or not meeting a deadline due to my caring responsibilities is a huge weight off my shoulders. I truly believe that having the support from my manager and the health board enables me to take better care of my daughter.
Thank you, and I think I've outlined in my chair's report some of the initiatives that we've taken over the last few years in respect of supporting our staff who are carers. There's always more to do, but I'm glad to hear that story from a member of our staff, the impact that some of the initiatives that we have taken have made on her personally and many others. So I'll refer to that again when I get to my chair's report. I'd also like to welcome today as well Dr. Jo McCarthy, who is a consultant in public health, and she's deputising for our Executive Director of Public Health, Mrs. Ros Jarvis. So are there any apologies? I have Rosas and Hashim Samia.
No other apologies, Chair.
Okay, thank you. If we could now go into the minutes of our meeting, which was held on the 30th of September. Are there any inaccuracies in the minutes? Now, the board's happy to accept them as a true record. Many thanks. If we could now go to the action log, and for those people who are watching our board for the first time, that's basically so that we can remember and ensure that what we said we'd do, we've actually done it. So if I could turn to the action log, if I could go to PM 21152, there was a request to WISC for consideration to be given to travel and accommodation requirements for parents and children undergoing paediatric orthopaedic surgery. Steve, do we have an update on that?
Yes, thank you, Chair. And also on the second of the bullet points there around paediatric cardiology. So just on that one to clarify, this is about thoracic, not about paediatric cardiology. That was confirmed. And I raised the issue around needing to give special attention to the travel and accommodation, particularly for our local population in relation to this, and WISC have agreed to pick that up as part of their commissioning responsibility.
Thank you. And then there was also PM 153, which was about the report will be shared with HEIW, and that's in relation to placements of students with us. Lisa, could you come in on that? Thank you.
Yes, certainly. The report will be completed next week. So we're in the process now of setting up a meeting with representatives from HEIWs either in December or early January. We have got one indicative date next month, but it will be ready shortly.
Thank you. And Lisa, will you be reporting the outcome of that to next board or to the People Committee?
We've been asked to report it to the People Committee, so we will do it via that route if that's okay.
Great, and then board can see the minutes of the people committee. That's fine.
Thank you, Chair.
Thank you. And then I've got 154 mandate in relation to the COVID thematic reviews. I'm not very sure about the wording in the progress. Does that mean we will have an overall thematic review report for Hywel Dda, or is that the general Wales overall thematic review?
So we are currently in the process now of undertaking the multidisciplinary directorate level reviews, and the expectation is that we'll collate all of those review findings into a report that we'll take through to our quality committee. The timescale for that, we're working towards the end of January to be able to have completed all of the reviews, which is a phenomenal task given the scale of the requirements. So as soon as that is completed, I'll take it through to the quality committee.
Thanks very much, Mandy. And if I could just pick up something from the minutes, I think it's page 15 of 30. It's where Councillor Gareth John requested assurance in relation to the bridging service, that if we were recruiting people for the bridging service, we wouldn't undermine the social care workforce. So in effect, we're not robbing Peter to pay Paul. I know we've gone down the route now and we've recruited some people to work for the bridging service, and I just wondered what the percentage of them come from the social care workforce, if any. Jill?
Yes, thank you, Chair. We did go out to advert. We've in fact undertaken 2 rounds of recruitment, as the numbers we did recruit were less than we'd anticipated in that first round. We have done that check. What we weren't able to do was through the advert to actually restrict who applied. From a legal perspective, that was defined as restricting trade, so we couldn't permit individuals applying for this who would be eligible. However, there are very, very small numbers who did apply, who have got another job. We've got 49 applicants altogether applied, but 16 then withdrew. So we've got about 38 whole-time equivalents left within the service. And there are some individuals who do have another job, but they've offered only a small number of hours to the bridging service, such as 7 hours, so that they're not actually affecting their current role. And what we were also able to do was to direct individuals who wanted a permanent position to our local authorities, actually, who were recruiting at the same time for permanent positions. And I think it's pleasing to note that some of our local authorities have done very well over this period as well, recruiting quite a significant number of whole-time equivalents into their services, which has meant that they have also been able to address domiciliary care requests for care at quite a significant rate. So I'm pleased to report that we haven't seen that, although I think in the round we would say that we're all fishing in the same pool, whether that's for the sort of social care sector, health, or even for other jobs within the system across, care in shops and all the rest of it. So I think it is the same pool, but we have recruited 38 whole-time equivalents into the service.
Thanks, Jill. I think that evidence is really important, because there's a lot of talk nationally in relation to the NHS taking the step that we've taken, and we've been at the forefront of this. But it's perception rather than the evidence. So this is an important piece of evidence that not only did we seem to be recruiting or robbing Peter to pay Paul, it's actually enhanced the recruitment process for our local authorities.
Yeah,
so
and
I think
I would also say that, always the intention has been that we would align this workforce to support the whole workforce. So in Ceredigion, for example, where they have got an integrated health and social care arrangement around the delivery of care within the community, the individuals, very small number in Ceredigion, will be aligned to that workforce. So we're looking at the best fit. And for example, we've got a couple of individuals in Carmarthen who've joined the bridging service who can't drive. So we're supporting them by the additional numbers we require in Amman Valley Hospital to support the community care in that way. So I think in the overall round of things, we're supporting that care within the community in the optimum way. And phase 2 of this process that we will be looking at in the new year is how we move far more to an integrated arrangement. So I think it's all positive in the round, and I think we just welcome the additional capacity in both health and social care to address this issue together.
Thanks, Jill. I'm going to bring in Steve on the same point before I come to Alison and Paul.
Yeah, just a couple of things to add. So I'm very happy to share, and I have done previously, the current update with my chief exec colleagues. I know in Cardiff they're having the debate with their local authorities, and the data we previously provided was helpful to that debate. It might also be helpful for me, Jill, to share it with the local authority leaders and chief execs at our next meeting, so we can just share the learning locally. I think there is a degree of positivity. I know in my update later, following our exec team on Wednesday, certainly in Carmarthenshire, it does feel like things are now starting to move in the right direction. The combination, I think, of bridging and the success that they've had in domiciliary care is starting to make a marked difference on the hospital. So we know it's kind of working as well. So we'll try and put together a bit of evidence. I'll send it to my chief exec colleagues, and we'll put it through the local authorities as well.
That's great, and it, you know, I know we're going to be doing a review towards the end for the learning in respect of this. So really look forward to receiving that. We're going to go out to recruit more.
At this time, the individuals that we've recruited are in the induction process and will be added into the workforce at the end of November. So it will be in the new year when we look to see the benefit of what has been successful across our social care workforce and the bridging care, and then review that position. Because whilst we've been doing this as an integrated executive group of the Regional Partnership Board, we've also been joined with our local authority partners, been doing a review of domiciliary care itself, looking at the reasons for leaving, looking at pay rates, and a significant work has been done to understand what the needs are for that sustainable future. So I think we'll be bringing all of that together, Chair, and then reviewing the need to go out for any further recruitment.
Thanks, Jill, and thanks, Jonathan, for your comments in the chat bar about being engaged in our local groups to continue to discuss, discuss career opportunities, and as you outline, offer permanent options for staff. Also put recovery funding support the dom care terms and conditions to retain and attract, and it's hopeful this will enhance recruitment. Survey being presented at a ministerial meeting later today. Thank you. I really look forward to seeing that actually, so we can learn from it. Thanks very much, Jonathan, and thank you very much, Jill. And as we said when we took this step together with our local authority colleagues, we thought that this would give hope at the most pressurised time that we have faced as a whole system. Thank you. Alison, I'm going to bring you in, and then Paul, and I know it was on a previous point.
Yes, thank you, Chair. I just wanted to provide a bit of clarity for the item 154 on the action plan. Mandy has actually put it in the chat bar. The paper or the report going to CUSEC is specifically around nurse staffing, linking with the Nurse Staffing Act and the stroke standards for nurse staffing. But we have recently undertaken or taken part in a national biannual audit of all the multidisciplinary stroke staffing team, but the results for that will not be available probably until Q1 of next year. That's not a complete review of staffing, it's an audit, but we will be picking up a review of our stroke staffing as part of the reinvigorated stroke redesign work. So I just wanted to be clear, I didn't want anybody thinking that there was a complete multidisciplinary review coming to CUSEC in December. That will be later next year.
Okay, thanks, Alison. And Paul?
Thanks, Chair. Two things now. First of all, on PM 21-160, you note from the figures which are given there that I think there's only one patient in Bwrdd who was medically fit and unable to be discharged. So I was wondering why the situation appears to be better in Bwrdd than at other venues. And building on the questions to the answers to the questions that have just been raised, whether we're looking at any other initiatives in order to try and address the issue. I'm aware there's been some coverage in the press about, I think, one trust in England looking to make grants to people to enable them to purchase their own care in order to allow them to leave hospital. Wondering whether we're looking at any other schemes to try and alleviate the pressures that we're under.
Thanks, Paul. I know you shared that at our meeting, the IM's meeting this week, so I'm not sure. I will wait for Jill to answer, but if you've got the details, I'm sure the exec team would welcome it. Jill?
Yes, thank you. And I think, to be fair, Paul, the numbers change on a very regular basis. And I think looking at the numbers of medically fit and ready to leave that we've got across our whole system now, those numbers would have increased in terms of Bwrdd. But I think one of the things that we're trying to do with our whole team is to look at our systems and processes so that we are making sure that we're putting actions in at the right place. We're looking at the front door, we're looking at the back door, as we've talked about in terms of domiciliary care, but we're also looking at our systems and processes within hospitals so that we're undertaking the assessments at the earliest point. We're putting those individuals onto our SharePoint at that earliest point, and we're beginning to prepare with the individuals, but also with our teams for that step down process or that discharge arrangement. Now, one of the things that we've talked about is domiciliary care and bridging care. We're also looking at the challenge, though, of individuals being able to leave hospital and creating pressure on those being able to be admitted. So individuals who may be in ambulances or waiting for care in the community are not able to get into hospital. So one of the other things that we're looking at is putting in a waiting service to support individuals who are waiting in the community, waiting for an ambulance, so that we've got good oversight of their care. But with reference to the point that you made, Paul, in terms of direct payments or an opportunity that I would assume relates to that type of arrangement, at the moment, direct payments for healthcare are not considered lawful at this point in Wales in terms of those who are assessed as needing continuing care guidance. And we know that that's not going to be addressed within the new continuing care framework that is due to be issued. However, we have had many discussions with the government and Welsh ministers on this point, and we know that it is something that they wish to continue to review. So I think there are ways in which we can look at that. So where individuals are waiting for joint care, we have entered into arrangements where their direct payments for the non-healthcare related elements of their package can be purchased through a direct payments arrangement with the local authority, and we work jointly with that effect. So that will be one of the things that we're looking at. We're also looking at step-down beds. We've purchased and block purchased a number of beds within facilities such as Lisa Bryn in Carmarthenshire, where we've got 8 beds currently. We can go up to 14, I understand, in that capacity. We're looking at also beds within our community hospitals, and we've recently recruited staff to surge our beds from Amman Valley into 20 up to 28. So I think we're looking, to be fair, at a menu of arrangements to ensure that we've got as many opportunities as possible to ensure that people get the right care at the right time. And I think as a health board, working with our local partners, working with WASP, the local authority, and the third sector, we're also another important part of that whole care arrangement. I feel that we as a health board are being very proactive in looking at the opportunities that are available to us within the frameworks and parameters that we're able to use.
Thanks, Jill. I wonder if I could bring Jonathan in about that particular question. The fleet of force have been able to give direct payments for the social care to discharge somebody from hospital. And is that okay, Jonathan? Are you able to come in on that?
Yeah, absolutely, Chair. I think Jill's given a really thorough outline there. There are challenges.
Sorry, you've gone mute, Jonathan. Switched itself off, I think.
System muted me. There are issues, I guess, in terms of flight of foot on a direct payment, and the issue mainly there is actually when we talk about recruitment, we've got recruitment challenges in most areas, including personal assistance that would support somebody with a direct payment. However, there are other individuals who get support through a myriad of methods, not just personal assistance, but also appropriate family members. So where that's the case, you can set up a direct payment in a fairly rapid time frame. So there shouldn't be, if there is a willing support network available that we can set up under a PA system, then most of our systems would allow that to happen at reasonable pace, I'd suggest.
And that's while people are in hospital.
Absolutely, you'd begin to you'd absolutely want to set that up in the same way you'd set another package up. You'd be setting that as you'd be assessing through that process.
Okay, thanks, Jonathan. Thanks, Jill. Steve.
I was just going to suggest that there are so many elements to this, and clearly it's one of our big issues, I guess, going forward, how we both end the bridging service in a way which is sustainable and actually strengthens the system, as Jill mentioned, the phase 2 part, and all the other. There's a lot of ideas out there actually about how we might be able to address the knotty problems. I just wonder, Jill, using the opportunities of the phase 2 thinking, whether we might want to have a board seminar, perhaps involving the Director of Social Care, just to have a look at the whole landscape of ideas and where we might go next. Not in the short term, because I think we've got in place what's going to help us get through this winter, but more in the long term. Just to have a bit of a discussion about that, I think it might be helpful. It feels like it's probably one of our key issues.
Yeah, I'd really welcome that. And I just feel that in West Wales we are leading the way on this. We're thinking outside the box. We're working really well in partnership, and we're focusing on the people we jointly serve. So I think getting together almost as an ideas workshop to test and bounce off each other, I'd really welcome it. Jonathan, you wanted to come in again?
Just wanted to mention that I would expect some national announcements, not to preempt that, but I would expect some national announcements in relation to the government's the programme for government in relation to the investment in social care. So I think that's an element we would bring into that conversation in terms of how that allows us, if we get the right sustainable investment, to redesign the kind of roles that exist, because integrated roles will work better in terms of maximising shift-based pay, etc., which could work across boundaries. When they work just in a domiciliary care environment and you want to move to sort of shift pay arrangements, you can have a lot of inefficiencies in those arrangements. So working together in redesigning the health and social care role is I think a welcome suggestion. And I'm sure colleagues will want to join up to have that conversation. Sorry, Jill, I can see you.
Sorry, if I could just ask also that we bring invite Hazel Lloyd-Lubran. She's the Vice Chair of our Regional Partnership Board and also leads the third sector representation at that Regional Partnership Board level, and is part of our integrated executive team. And we work really collaboratively as local authorities, health and third sector. So I think she would be a welcome addition to that discussion, if that's possible, please.
Absolutely, Jill, we'll do that. And absolutely be a health social workshop almost. And as you say, it's great to hear there's going to be more announcements with the programme for government. It's how we use it, isn't it? And how we do it quickly together with all the best information about our area. And even though I see on the chat bar it's going to be discussed at the RPB, I think it's really helpful if us as deliverers get our heads together and feed into the RPB because we can actually make it happen. So yes, I think there's a lot of support in the chat box. Steve?
Just I saw you and put it on the sidebar, but there's a discussion to have in all of this around the micro-enterprise, which links to the foundational economy work as well. So there's some interesting things I think we can bring in around the table.
That's great. Thanks everybody. Welcome, Baba. I know we're only on the minutes here, but I think it's a really important conversation and I think it's borne some fruit. So diolch yn fawr everybody. Next item on the agenda is my report. You have my report before you, so I'm not going to go through it in detail, but I'll just pick out a few things within there. First of all, unfortunately, we've had to take the difficult decision to temporarily suspend visiting to patients in all our hospitals because of the significant increase in COVID infections. And this is being kept constantly under review, and our family liaison officers and our patient support teams are helping patients and families to keep in contact with each other. And as soon as it's safe, and there are exceptions to this temporary suspension of visiting in end-of-life care and birth, but as soon as it's possible, we will lift that restriction. I'd also like to refer to our vaccination campaign. And as you know, this has been the biggest in the history of the NHS and continues to be delivered at pace and is undoubtedly saving lives. There have been some challenges recently with the booster part of the campaign, which we have had to deliver from mass vaccination centres as our primary care colleagues had started to return more to face-to-face appointments with their patients. And also we've had to use Pfizer vaccine, which is very difficult to store and to transport. So at the beginning of the booster campaign, there were some issues with missing and incorrect information and directing people to vaccination centres which were very far from their homes. So we sincerely apologise for that. And I know that we've also been offering compensation to those people who contact us to help reimburse expenses. And I'd just like to reassure the public that transport support is in place for those who need it. There's disabled access at every mass vaccination centre, and if it is difficult for people to access the buildings, staff are always willing to give vaccines within the car park. And I'd also like to take the opportunity to thank all our staff in the mass vaccination centres, and those who are on the bus and those who are reaching the most difficult to reach people to ensure that they get their vaccines as well. And many of who have come out of retirement, they are doing an amazing job opening long hours to make sure everybody who wishes can receive the vaccination. Another part of my report, I refer to the vaccine vial wreaths, which were made by the VC Gallery in order that we could lay poppy wreaths, or the equivalent of poppy wreaths, during Remembrance Sunday. That was a very emotional day for many of us, and we laid the wreaths in each of the 3 counties at many of the key centres, and they were very appreciated by the public, and also open conversations about how the vaccines had changed many people's lives, how they were able to return to their communities and live their lives again. So thank you to the independent members who laid those wreaths, and thank you for the VC Gallery and our team who enabled that to happen. I've also put in my report about the Royal College of Nursing Wales Nurse of the Year Awards. Forgive me for the vernacular, but we absolutely smashed it as Hywel Dda. Our nurses did incredibly well. We won 3 categories, and we're runners-up in 5. A wonderful, wonderful achievement. And I'm sure you will all join me in congratulating them all. And we had our own celebration, which Steve and I attended a week ago in Park Scarlett, and Mandy and her team organised. And it was wonderful to see the difference it made to everybody, particularly after the 20 months that we've won so many awards and been recognised. I think traditionally we kind of keep our light under a bushel in West Wales, and it was great to see it shining nationally. I'd also like to draw attention to Emma Kay, who was shortlisted by the Royal College of Midwives in the Midwife of the Year Award. And finally, I'm so pleased to say that the Minister has reappointed some of our really valued members. So that's Anna Lewis, Anne Murphy, Maynard Davis and Hazel Lord-Lubran, who's also the chair of the stakeholder group. So thank you for continuing to serve on the board, and look forward to working with you over the next few years. So open to questions. Lots of comments in the chat bar in respect of congratulating our nurses and the moving Remembrance Day ceremonies. Any questions? Are the board happy to ratify the actions? Sorry, Mandy, did you want to come in?
I was just going to come in, if I may, on the issue around visiting, because obviously I realise and absolutely appreciate the distress that any restrictions to visiting may place on family members and in fact patients who are currently in our areas. It's just to reassure everybody that we do undertake a formal review on a Monday of the situation, and we take into consideration not just the community prevalence but also what's happening in our hospitals and our clinical environments. We're currently working on how we can actually safely reinstate visiting into all of our areas, and we hope that we'll be getting something out to the public very shortly, certainly by next Monday. So we'll work on that and make sure that we can lift as much of the visiting restrictions as we possibly can, and hopefully we will be able to support visiting over the festive period whilst people are unfortunately in hospital with us.
Thanks, Mandy, that's really reassuring, and I'm sure the public will welcome that. I think if we could perhaps get that out as some sort of a communication press release so that people know what the plans are and how we keep reviewing the situation. Delith.
Thank you, Chair. Diolch, Bwrdd Dda. I've got 2 questions, if I may, and they're very, very brief. One about the immunisation booster letters. I have been approached by members of the community that there still remains a difficulty and confusion about the booster letters, which is impacting on some of our elderly patients in the community. So I'd like some reassurance that that issue is being looked at and managed appropriately. But also on a plus note, congratulations to all our nurses, coming from an old nurse. Can I ask how we are going to promote the learning and the good practice within our organisation to actually improve our patient care as well? So there's two questions. Diolch.
Thanks, diolch, Delyth. And I'll bring in Alison in relation to the booster letter. Thank you. Alison.
Yeah, thank you, Chair. Thank you, Delyth. I think that's an important question. Unfortunately, we have had some issues. We've had a number of issues with the letters. I have to say some of it is outside of our gift. There's a number of issues relating to the national script, and also we've recently picked up that there may be some problems within the postal system. So I can't assure you that there won't be any other issues going forward, but what I can assure you is as soon as the team are made aware that there is an issue, they will continue to act on it as quickly as possible to put it right. So if the specific issue you're referring to is already known to us, yes, it will be being put right. But what I would say is if anybody does pick up any future issues, please let one of us know and we can look into it straight away, and we can get onto it and sort it as quickly as possible.
Thanks, Alison. And Steve?
Yeah, I was going to come to this in my report as well, because I know there have been some concerns, Delyth, around the level, around the letters and some of the areas that they've been, which have caused, undue concern for people and some real inconvenience for people. The team have also asked for assurance on our processes. So we are using a locally procured company for as much as we can of this now. As Ali said, some of this is national, but also they've looked at all of the data handoff points, because there were probably too many in the letter development process, which then led to the opportunity for error to be brought in, and they've significantly simplified the process so that it should, as Ali said, you can never give absolute guarantee. This is a huge programme, and we're relying on the data that we've got as well, which is never perfect, and systems that are not all entirely in our control. But I am reassured the team have really looked hard at what we can do to improve the situation and reduce the risk of something else happening.
Thank you. If I could bring in Mandy on the learning question.
Yes, thank you for that one. And I wish I had a single solution, one size fits all, but I don't. But I think one of the things that we need to continue to do is make sure that we share what we do, what we've learned on national platforms, whether that's through conferences, whether it's through posters, presentations, award ceremonies or whatever. There has been a reluctance for people to submit in the past, but I think the more that we gain confidence and we see our confidence being rewarded, the more people are likely to share. Certainly internally we're sharing, but only this week I've met with Improvement Cymru to look at how we go further and what's next. So watch this space, and I'll see what more that we can do to make sure we're spreading across not just Wales but the wider UK and beyond.
Diolch, Mandy, thank you. Are the board happy to support the work engaged by myself since the previous meeting and ratify the actions undertaken by me on behalf of the board? Thank you, Diolch. The next report is the report of the Chief Executive, Steve.
Yeah, thank you, Chair. Just a couple of things. Firstly, just to add my public congratulations to the IM reappointments. Great to be continuing to work with you all. Really pleased to hear that yesterday. I guess I just want to, just by way of context, just to recognise and to apologise for the fact that it feels like we are in quite an unusual environment at the moment. I think it's the same for all health boards in Wales, but the speed of decision making, the need to make things take actions quite quickly, I think it's meant in some cases we haven't kept the IMs entirely informed about where we are. So there may be some things on the agenda today that look a little fresh, if I could put it that way, for the IMs, and I do apologise for that. It is partly down to, as I say, this extremely unusual environment we're in, particularly around finances, that we're trying to work as fast as we can with. But we will endeavour to make sure that as things do come through, we keep the board fully informed, even if that's not fitting particularly well with our public board schedule. My report covers a number of things. Just wanted to highlight a few of them. You'll see the Clwyn-Hendy TB outbreak review in my report with a slightly amended terms of reference. Phil, the medical director, and I met with local councillors to discuss this about a week and a half ago in the area. And I think we were able to answer a lot of their questions at the time, and they were very supportive. So I'm really pleased to see that this is restarted now. I think an important piece of work, not just for Hywel Dda or indeed for Wales. There may be some real learning in this for the UK. You will also see in my report an update on agile and hybrid working. There's been so much change in the last year, and trying to grasp some of that, but also ensure that we have the facilities and the accommodation that we need. We've got some really interesting developments like our new command centre, for example, and the single point of contact that Mandy's working on, which needs accommodation. We've also want to try and take stuff as far as we can of our hospital sites, which are non-clinical, to both improve the parking and also increase the amount of clinical space. I think probably in broad terms, the agile working agenda is really only now starting to come into focus. So I think this will be there will be more to come in this. But I am looking today for approval in principle on the lease of Glean House, but we will bring those decisions back to board once they are once we are further down the track. But it's about making progress, as I say, in this slightly unusual environment, the speed with which these decisions need to be made. Happy to take questions on that as is Lee and the team. There's also a set of actions in here around the Public Service Ombudsman review of a complaint in relation to our care for a patient requiring psychological services. Firstly, again, apologies to board members. This may have felt like it came a little out of the blue. I think it is something that we're reflecting on. Mandy and I have discussed, but again, I think it's just a symptom of the system we're in at the moment. I'd also want to apologise to the patient and the family for the circumstances of that. And I've set out in my paper the actions we'll be taking to pick up on that review. On a slightly more positive note, we've signed our memorandum of understanding with Aberystwyth University a week or two ago. I think it's a real testament to our developing and deepening relationship with the university in Aberystwyth, and I'm genuinely excited actually about what future possibilities there can be for Mid Wales in relation to what they want to do and what we want to do, and ultimately bring benefits to our local population. And it was great to be able to walk around the new nurse training facility, which will be starting to receive nurses in the summer to start their courses. So fantastic step forward. And then I will forgive board members for not having read the 1,000 pages of the radiology informatics system procurement papers that I think were attached. This has been a massive project actually going on nationally now for a few years. I've been probably more versed in it than others because of my role as the imaging lead for Wales. It is here for approval today. The reason it's important and our radiology community is really calling for this is it brings together our ability to do picture archiving and radiology information systems into a single system, which makes it so much more seamless and more workable, and allows our teams to work together across health board boundaries as well as internally. The exec team met with the national team who've been leading on this last week. It is a huge and complex programme because it involves so many sites, so many systems. We did raise some issues around ensuring we had the business change, particularly linking to our radiology teams locally, so that as the system goes in, we have the right change in procedures and the way that they work to be able to support it. But as I say, I'm really encouraged by the level of enthusiasm from our radiology teams for wanting to get this done. So I'm sure we will get that right. And it is really good to see that this has now reached this milestone, because there is also a sense of urgency about getting this done, given the age of the current systems. There's another number of other things on my paper, which I'm really happy to take questions on either those or anything that I've covered.
Many thanks, Steve. Gareth, John and you and Thomas have indicated they'd like to ask questions. Gareth, would you like to go first?
Thank you, Chair. Yeah, it's on hybrid working, if I may. If you could I have an assurance that we've explored and made contact with all our public sector PSB partners, and that includes Welsh Government as well, with regards currently underutilised or vacant office accommodation within Carmarthen Town, in and around Carmarthen Town Centre. which would also have the added benefit, of course, of supporting our town centres. The other point I'd raise is that are you aware of the team? I'm sure they are aware of certain issues with the proposed site, especially around traffic congestion, etc. But my main concern is to seek reassurance. This is a private lease, so have we explored all the possibilities with our partners? Thank you.
Yeah, thanks, Gareth. I might bring Lee in on that if I may. But just to put, I know we know this, Gareth, but the great work that's going on in the old retail building, the vacated retail building in the middle of Carmarthen is going to be a great step forward for us. I was really pleased to see that announced in the budget. But yeah, your point is well made, and I'll ask Lee to respond.
Yeah, thank you, Stephen. Thank you for the question, Gareth. So we have made inquiries with local authority and Welsh Government about the buildings in Carmarthen town specifically. There's I guess there's a timing issue for us at the moment with some of that. So the local authority, we know, are undertaking a review of their buildings and are not at a point really for us to consider alternatives. We have had some offers provided to us, but what we need to consider is the suitability of those for the specific proposals that we've got here. So as a principle, what we want to do is work with public sector organisations to develop hubs. I mentioned that at the last board meeting, and we're working with the Carmarthenshire County Council on the Llandilo hub, for example, and we'd like to do that across all of our major towns. So where there are buildings available to us, we certainly want to explore those and work in collaboration with all of the public sector partners. On the greenhouse specifically and the traffic and parking issues, that we are aware of that as a constraint. It's not perfect, but equally there aren't an abundance of administrative kind of accommodation in Carmarthen to choose from either, so there's always going to be some level of compromise. It has been fully occupied previously, so we know what that would involve. And we are looking at whether we can secure some additional access to parking spaces adjacent to Greenhouse to try and alleviate some of the parking pressures. But we are aware that is potentially a problem.
Thank you, Lee. And Welsh Government?
Yeah, sorry, we did. We have specifically looked at the building you're referring to. We've walked around there again. It's about finding the right use for that facility, I think, because it's I guess it's point of detail, but it's an open plan office space, so we'd have to think about how we use it. And again, the same issue applies, probably more so in terms of traffic and parking. So for the specific purposes we've got in mind, we didn't. The conclusion from the teams was that wouldn't be appropriate or wouldn't be the most. Wouldn't be the best proposal, but as a future facility, that is certainly in our thinking.
Thank you, Lee. Thank you, Gareth. If I could bring in Ewan.
Thank you, Chair. Bwrdd Dda, really to support what Gareth's kind of query was in terms of the additional office accommodation, and was fully supportive in terms of looking at staff in terms of how we can best serve them now in the current climate. We're looking at in Appendix D of up to 100 desks in terms of being accommodated at Greenhouse in Johnstown. And whilst we fully appreciate that there won't be 100 people there at the same time, I think it's again perhaps the social responsibility of Hywel Dda to look at how we kind of further integrate into our communities. And very much welcome, obviously, Lee, as you say, in terms of the discussions with local authority partners. But I think, in terms of Carmarthen, Haverfordwest, Llandilo, Aberystwyth, our kind of opportunity to really make a contribution, a positive contribution to the local foundation and circular economies in terms of having our kind of staff located within those urban centres will make a huge difference to many of our local businesses who are relying on that additional footfall. So again, I think it's just that kind of plea really to kind of continue those discussions with our public sector partners, as I know you and colleagues are. And the instance of Carmarthen as well, Gareth's right in terms of perhaps some of the logistical issues in terms of Greenhouse in Johnstown, and where we know that perhaps the local authority has perhaps some vacant stock already in Spilman Street, which are already established as local authority offices, and with minimal upgrading, I'm sure would more than service our requirement as Hywel Dda, in the same way that there are similar instances in Haverfordwest and Aberystwyth, I'm sure, as well. So absolutely agree with the premise of why we're doing this, to support our staff in terms of the current climate, but again, a plea really in terms of what we're doing as an organisation has a huge impact in terms of our local supply chains and our local businesses, and I think it's, you know, part of our remit to make sure that as one of the biggest employers, if not the biggest employer in the region, we really look at where we're expanding and changing our kind of circumstances in terms of support services to integrate within those communities, to really support those other businesses and to show that we're leading from the front. So yeah, thank you.
If I just respond to that, Ewan, so I think we're in complete agreement. So I think there's a couple of things we're obviously looking to. I guess the starting point for this is to create some additional clinical capacity, particularly on Glangwili site, and avoid over congestion on some of those sites. So we're looking at opportunities to address that, but that applies to all 3 counties and all sites that, within the health board. I think what we said previously on the hybrid working paper that we brought aboard last time was exactly as you say. There's an opportunity here to benefit both individuals who work for us and giving them some flexibility in the way that they work, the organisation as a result of that, but also our local economies and actually the broader environment as well. So I think there's a win-win-win there across that. So we're keen to develop those hubs and those facilities across each of our main towns, actually. So there's a lot of opportunities there, and that's certainly the direction of travel for us.
Thanks, Liam. Thanks, Ewan. I'm going to bring in some more questions. One is from the CHC and then John Gammon. Could I ask people to keep their questions short, because we're really eating into time this morning? John, sorry, CHC first, Mansell.
Oh, thank you, Chair, and good morning, everybody. It's just about the cardiac services that Swansea Bay staff are collecting patient experience. I'm assuming that that's being shared with yourselves, and I wondered if you'd be kind enough to share it with us, because there's a lot more services now going out of area for commissioned, and we would like to see that being done. Thank you.
Thanks, Mansell.
Yeah, I think our plan, Mansell, would be to bring it to board at the appropriate time, so they'll be in the public domain, and then obviously share with the CHC at the same time. Thanks,
Steve. John.
Chair, can I seek assurance from either the Chief Executive or from the Director of Planning and Strategic Development in relation to the Appendix F? Within that letter, there are a number of work streams and work programmes that are equally covered by Arch. And I'm just a little bit concerned that we're creating duplication, or in danger of creating duplication. My understanding is that regionally we use the platform of Arch for the development of some of these programmes, for example, the cancer programme that's noted there. So just some clarification, Chair, would be helpful for the board.
Lee might want to come in, but just to reassure John, we had a meeting, actually, exec to exec meeting with the Swansea Bay team yesterday, absolutely using the newly refreshed Arch governance as a way of doing all of our business, whether that's through the regional recovery work, the more strategic development work, or indeed the Arch partnership work. So all of this being routed through that governance system.
Yeah, just to confirm that point, so the letter was in response to Swansea Bay's engagement through the summer, so that was our formal response as a health board, if you like, to their proposals, and they were really just referencing the discussions we've had through Arch and the work that we're doing through Arch. So we're not intending to set up any work streams outside of that Arch umbrella. So just to give you that assurance.
Thank you, Chair.
Thank you. Can I also ask a question about that particular letter? Why is the hazard just for Swansea Bay residents at this stage, and when will it be reviewed? Because that seems to be a real change from the pre-pandemic discussions.
I'll bring Alison, and we did discuss this yesterday with their exec team. But Ali, did you want to comment?
Yeah. I mean, the members all will remember that we were doing quite a large piece of stroke redesign work, several strands, one of which was the joint HAZU in Morriston, and all of that work had to unfortunately be put on pause because of the pandemic. We've recently restarted the discussions, but Swansea Bay have been quite clear that they now want to look at establishing the HAZU in the first instance for Swansea Bay residents only. So that is, but I think there may be an opportunity to have that further conversation with them. I picked that up with Lee and with Phil yesterday, but at the moment they are saying that they want to establish a HAZU from a Swansea perspective in the first instance, and it's quite important that we have a decision on that, because obviously that will impact on our own regional discussions around our stroke services going forward. So I couldn't give you a timeline at the moment. We've not had a timeline from them, but knowing how complex this redesign work is, I would imagine it would be 18 months, if not 2 years, before we potentially started to open up any conversation with our residents being able to access the HAZU in Swansea, unless they rethink that decision.
And Alison, as a health board and the work that was done previously, what do we think is the best for our patients and our residents in Hywel Dda?
I wish there was a very simple answer to that, Maria. What we actually need is a different solution for the short, medium and the long term. And I think we need to restart those conversations around the longer term when we have our new hospital, but also what do we do in the short to medium term. I think we can work a solution up with Swansea for part of our population potentially going to the HAZU, but I also think that we can put in a solution if that's not the case. But we need a clear direction of travel before we start to get into the detail of the work.
So I think my view, and Ali and I have had a couple of conversations about it, and as I say, we did discuss it with the exec team yesterday, is they do feel they need to get their sort of house in order around this, but I don't see it as a finished conversation between us, particularly in the medium term part of what Ali's described.
Yeah.
For the long term, I think there is a different discussion to have, because our new hospital does give us an opportunity to do something more locally. Of course, with stroke, particularly this area of stroke, the distance travelled and the time is a really key factor in all of this. So ensuring we've got that right first is probably the biggest part of the puzzle. But I would expect us to keep this on Swansea Bay's agenda, and that what they're describing at the moment is very much a temporary situation.
Okay, so where are we going to scrutinise this as a health board as these negotiations go along, the short, the medium and the long term solutions, particularly the short term? Is that, which committee would that be?
Planning objective.
Yes, it is a planning.
Planning SDOC.
Okay, so can I refer that to SDOC then, please? And we're very fortunate in that we've got the lead nurse nationally based in Bwrdd as the advanced nurse practitioner, and I know nationally, and she's working with Shaquille, who's the lead clinician. They have got views about what's best as an overview. But if we could get assurance and keep informed through SDOC, please, on the development of this planning objective.
Absolutely, and we're all aware that the national view is that we need to have more regional services. So I don't think the conversation is over.
Yeah, that's grand. And I think we as a board, I think we should be pushing that as well. If I could share that with my colleagues. Yeah. So thank you very much, everybody. So in relation to Steve's report, are the board happy to endorse the register of ceilings? Well, all the recommendations, but I will just put in in principle, it is in there, note and approve in principle the new lease arrangements for Gillian House, which caused the most discussions. Paul, did you want to come in, please?
No, I just going for the next item. So.
Okay, thank you.
Sorry, can I just check the governance in principle, because we do need the board to approve and able to go ahead with the lease. So I know it's in principle, but we do need it because it's in accordance with our standard financial orders. It's over the limit. We do need the board to make that approval.
Okay.
It is in principle, because we will then have to follow the processes through the lease team. Okay. But just to be really clear in the governance.
Thanks, Joe. So based on the assurance that the board has had in relation to the negotiations that have been undertaken with our public partners and with Welsh Government, and the fact that those particular, the accommodation that is available or may come available is not suitable for what we want to do, are the board happy to approve the lease arrangement for Gillian House as well? Yes, happy to support, yes, coming from there. Thank you. No? Gareth, do you want to come in?
Only for the record that I would not support at this stage of the information received the principle of proceeding with a private lease. Only for the record. Thank you.
But we can go ahead on the majority.
If the majority are happy, Chair, we can progress. Yeah.
Okay, that's grand. Thanks everybody, and thank you for all speaking very openly and frankly about this. So the next item on the agenda is Paul, proposal ARA.
Yeah, thank you, Chair. It's the report from the meeting on the 19th of October. You'll see at the end of the report there are 6 bullet point items that we're drawn to the attention of the board. Each of those are issues which the committee are continuing to deal with, and as we highlight, are awaiting further responses in some cases to the management responses, but nothing else to for the board to be particularly aware of.
Thank you very much. Has anyone got any comments or questions on Paul's report from ARA? I wonder if no, that's grand. Thanks, Paul. Thank you very much. We go on to the next is the Quality and Safety Experience Committee. Anna.
Thank you, Chair. Yeah, I have nothing to add to my report, but I wonder if I might just take this opportunity, Chair, to recognise just how challenging the quality agenda is right now. And the impact that has from time to time on patient experience. We don't always get that right. So I wanted just to take the opportunity to thank our communities for their forbearance and their understanding, and also especially to our staff and partners for working absolutely flat out to do the very best that they can in some very difficult circumstances right now. I'm happy to take any questions.
Thanks, Anna. I just wondered if I could also bring Andrew in on this, because it's in the report, your report of the committee about the Kilgarran environment, and I know there has been discussion since your committee, which Andrew might want to give us a brief update.
Chair, Andrew's got IT. Andrew's got IT difficulties at the moment.
Okay.
I think Mandy may be going to help with that one when Andrew rejoins us.
If you can, otherwise we can bring him in later on.
Yeah, it may be helpful. I was just going to say that Andrew's having IT difficulties, but I know that we are doing some work to try and improve the environment in Kilgarran, but he will have some further details, I'm sure, because of the work he's taking through the Children and Young People's Board.
Thanks, Mandy. I did have a meeting with him yesterday, so there has been a lot of movement in that respect, and I think the board would like to hear that. So we'll take it further down the agenda. So thank you very much, Anna. So the next is the Board Assurance Framework, please, and that's Stephen Joe.
I'm happy to hand over to the Board Secretary.
Yeah, thank you, Chair, and thank you, Chief. Just to update the board really, so you can see in this Board Assurance Framework, we're trying to now get the focus to move away from looking at this as a process tool, so that you can now start using this to inform board agendas and actually to look at what this is really telling us in terms of outcomes. So there's just a few things really to cause the board's attention. We've got now 4 planning objectives to complete, 39 on track, 1 behind, 1 ahead and 9 behind. So just looking at strategic objective 1, into that relates to waiting list initiative, that's slightly behind. And I guess it links to some of the papers that we've got today on the board agenda, because the risks, and you can see from the outcomes, is in relation to the patient experience, and also our highest risks are in relation to attracting and retaining our workforce. So I won't go through each of the strategic objectives, because we've listed in the paper for each what the key risk is, what that relates to the outcomes. But we really do as a board need to start looking at this now in terms of those outcomes, rather than just looking at, isn't the BAF a nice process?
Yeah.
And start using it in terms of the agenda, which you can see we've tried to rejig the agenda slightly today with the patient experience report following, Chair. So I'm happy to take any questions.
Thanks, Joe. Open to questions, please. Joe, could I pick, well, it's not for you, but page 5 of 8, about making every contact count. I just wanted to ask, are we implementing that in the max vaccination centres when we have all of our public sitting for a wee while with our nursing teams, and are we bringing third sector or other partners in to to implement that? Is that you, Alison?
Yeah, I can answer that. I think we use the term making every contact count in different ways. So we've got the wider making every contact count programme that we tend to use for promoting health and well-being and nutrition and physical activity, smoking cessation, etc. We're not doing that in the max vaccination centres. That would actually take quite a significant staffing requirement to do that, to actually be meaningful. However, we are using the making every contact count principle in the mass vaccination centres, in that we're taking the opportunity to do things like atrial fibrillation screening while people are there. So there is an element of making every contact count, but not in the traditional sense of providing any sort of detailed conversation around smoking cessation or activity or signposting.
Have we got any plans to do that, Alison, in partnership with other organisations if we don't have the workforce?
We don't have plans to do that at the moment. I mean, I can certainly take it back to the team. I think certainly from a health board staffing perspective, that would be quite a challenge. There's a possibility, I guess, of us looking at whether we can bring other people in, but I think the challenges around that, off the top of my head, would be around the space and the environment. But I can certainly take it back and have a conversation with the teams to see if there's anything that we can do. We may be able to do something on some sites, maybe not on all of them. But that's actually quite a sort of significant ask, but I can certainly pick it up with them.
Thanks, Alison. It was raised by the Minister for Health, because
right.
we have a sitting population really, and access to everybody.
Steve. Just to add to that, I mean, I think absolutely. Thanks, Alison, for picking it up and looking at it. The gestation of this planning objective was really around recognising that our therapy teams, in particular, have a lot of public, and therefore have both the time and opportunity, as you say, to do meaningful contact. I think it is worthwhile trying to look at it at our MVCs. Of course, what we do need to balance that with is not just the staffing issues that we might have, but as you sort of mentioned, we need to get as many people boosted and jabbed as possible, and that requires throughput. So it's just balancing out needs to be struck. And as you say, we could probably do it more easily on some of the larger sites than maybe in some of the ones that are already challenged, but it's certainly something we need.
Okay, many thanks for that. Are there any questions, please?
Chair, sorry, it was just me in the chat. There are two errors in the paper that I forgot to bring out to board members' attention, and that's just in relation to timing. We have noted in the paper that at the seminar in December we'll be looking at outcomes, but what we've agreed is that we'll postpone that until later in the year, just to let some of the work we've already done settle in, and then see what other outcomes we want to look at. And we also mentioned in the paper that the planning objectives would be at this board, will actually be the January board, so I just wanted to correct those errors, Chair.
Thank you, Chair. And thank you very much for this very helpful reporting too. And as you say, it's about getting into the detail from now on, rather than just looking at the actual process of it. Yeah, okay, thanks very much. Okay, if we can then go on to the next report, which is improving patient experience, and that's Mandy.
Yes, thank you, Chair. I'm pleased to be able to provide this report to you today, even though it doesn't give us a picture of complete patient satisfaction across all of our services. I would like to start, though, by thanking the family who are captured within our patient experience story. I think what the story demonstrates is that when you put the right sort of support into a family, it doesn't just make a difference and have a positive impact upon the outcome for the patient, but actually a family as a whole. And I think that's something that's really important when we're thinking about how we care for patients. We aren't just caring for the patient in front of us, we're caring for the wider family and support network that they live with and are supported by. You'll see that the number of concerns has reduced in the period, but that doesn't reflect the fact that we are seeing several hotspots in terms of adverse feedback on the experiences that our patients have when they come to some of our services, particularly in our emergency departments. But we've also seen a deterioration in the level of satisfaction being expressed in a number of our inpatient areas as well. What I would say is I think that the level of satisfaction and the feedback that we're receiving is proportionate to the level of significant pressure that all of our services are under, not just our A&E and ITU departments, but actually every service from primary care all the way through. I would like to draw your attention to the tables on page 7 of 26 of the report, as I think these illustrate at a glance the areas where the percentage feedback is less positive. And that is a mechanism that we're going to use to be able to provide some extra support or extra oversight so that we can better understand what actions we can actually take to improve experience. What I would like to call out, however, is that what you see in the report and what we're beginning to see is that we've now got 7 times the volume of positive feedback in relation to staff attitude. And members will recall, and members of the public who have listened to us before will recall, that staff attitude has been an issue that we've been trying to tackle, and it's been a constant theme. But I'm pleased to see that we are now beginning to make some progress on that. And Lisa, the workforce Director of Workforce and OD, and I had the privilege of seeing a prototype of the Making a Difference customer services support training that we're going to be providing going forward from the new year. I think that is going to make a phenomenal difference when it comes to the values and behaviours that we encourage of all of our staff. So that's a real positive. And I just, the final thing that I want to call out within the report is that I'm absolutely delighted that we've been able to appoint 2 individuals into our Arts in Health coordinator post. The role is funded, or roles, because we've got 2 of them, are funded through the Arts Council, our joint work with them, and through a grant there. And it's really, really pleasing to see that the impact that they're already beginning to have. They've only been in post a few weeks, and even before officially starting, they'd secured a significant amount of funds for us to be able to do an Arts in Health project with children and young people in the mental health environment. So I'm looking for great things to come out of that particular project. But I'm open to taking questions now on any aspect of the report that members would like to ask.
Thanks, Mandy. I'm going to bring in Judith and John for questions.
Thank you, Chair. Mandy, first of all, can I echo what you said about the Arts and Health coordinators? I think it's really inspiring that we've been successful. My question relates to a comment you made about having feedback from all areas, and I'm particularly interested in mental health and feedback in mental health and learning disability services from our users' services and also families and carers. I know from my role that we do have feedback from carers, and there are quite a lot of mechanisms where we meet with carers and those with lived experience of the service, but we don't seem to see that coming through this report. So I'd be interested in timescales for you to do that, please. Thanks.
Absolutely, thank you, Judith. And in fact, I'm going to be doing some further work with our mental health and learning disability colleagues on a range of areas. But the specific focus around mental health and learning disability feedback, I'm sure that we can bring something back into the next report. It may not be in the depth that we would normally be able to provide, because we are working on the introduction of the new system from January, but that will then be rolled out across all services. So I'll pick it up with Louise after today's meeting and look to see what we can bring it back in the next report.
Thank you.
Thanks, Matt. Just if I could just pick up the issue about the arts in health. Paul has asked, is it possible to involve our university art departments in the Arts and Health initiative? I'm sure it is, having met the coordinator, one of the coordinators, that they're doing absolutely everything they can. But if we could pass that on, that'd be great.
Absolutely.
John.
Thank you, Chair. Can I echo Mandy's comments with regards to values and also staff attitude? That's, you know, encouraging to see on page 7 that the work that our OD team have been doing around values, etc., now is beginning to have an impact. And the graph on that page certainly shows some positive developments in that area. However, if we look at page 15, it's quite interesting to see that we read comments from the public that are quite converse to that, where many of the examples that are given in terms of what our public want to see better is communication and staff attitude. So I think we're moving in the right direction. But I guess my question is, it would be useful for the board to hear what is the ongoing work between Mandy and the OD team with Lisa around attitudes, values and communication of our staff. And secondly, if I may, Chair, just comment with regards to the epilepsy service on page 25. It is so encouraging to see the work that has been done to improve that service, which has been a challenge for us as a board in terms of staffing, and that the regional approach that we're now taking and the additional appointments seems to be having a positive impact on those individuals who require those services. So well done.
Thank you, John, and thanks for that kind comment, because I think the teams have been working exceptionally hard, particularly in the area of epilepsy, and what we can do to support that particularly distressing often condition for the patients and their families. In the context of what we're doing on an ongoing basis, I'm sure Lisa may well want to come in actually, because the work of her team is really beginning to have an impact, particularly through the relationship managers and the ongoing engagement work that we're doing. I mean, the one thing I would say is that whilst I wouldn't excuse anybody's attitude or inappropriateness with any member of the public or our patients, I think the significant pressures that our staff have been working under hasn't always brought out the best in people, because at the end of the day we're human beings. But certainly the work that Lisa's team is doing with the nursing workforce is beginning to pay dividends. So Lisa's here, so I'm sure she'll come in.
Thank you. And just to pick up on that, what we've introduced within our OD team now is a referral process. So whereas before people were linking in with different members of Christine Davis's team, so whether that's staff psychological wellbeing or whether staff experience or OD relationship managers, we now have a process whereby when we become aware of an issue or things like the report that we've seen today, they will come into the head of the relationship managers team, and they will then look at what's the most appropriate intervention and support that we need to put in place with a service. So what will then happen is there'll be a series of conversations with the leadership team of that area, and it will either be staff psychological support, it will be staff experience, it will be some cultural reset work. So all of that is taking place at the moment. And then, as Mandy mentioned earlier as well, our Making a Difference programme really is phenomenal in terms of how to make a difference to our patients, our public, our colleagues and ourselves. So we'll be very pleased to be presenting that to the Health Board shortly.
Many thanks. Thank you both. There was a question, well, there's a request in the chat bar from Winston. So as well as reporting some of the mental health feedback, could we also have more reporting within the report on primary and community care experience?
Absolutely, I'll pick that up with Louise as well and look to see what we can pull into the report.
Mandy, you quite rightly drew our attention to the deterioration in patients' experience in A&Es, which is obviously related to the whole of the system pressures from the community right through to discharging people into social care and social care itself. What are we doing practically to enhance the experience in A&Es, even if we can't reduce some of the delays? So I'm picking up things like, chairs, blankets, hydration. I know we've got the Red Cross going in, so it'd be grateful if you could expand on that.
So certainly in terms of our A&Es at the moment, again, Lisa and I are engaged with her OD team, looking at how we support our workforce, because actually if we support our workforce, then they will ensure that our patients and the environment in which they're cared for is at the standard that we would expect. On a very practical level, certainly last weekend, or the weekend before, actually, time flies, the senior nurse, for example, in ED, did a walkthrough of the waiting rooms and with the facility staff, and has actually made sure that the area has had a deep clean, that the area has been decluttered. I've asked them all to revisit the furnishings across all of the areas in those waiting rooms, together with our health and safety and infection prevention control team, partly because we need to maximise as safely as possible the numbers of people that we can have inside the building whilst they wait for their care, but actually looking at the intervention of our Red Cross colleagues, looking at the intervention of our flows, our liaison officers, so that actually when people are unfortunately having to wait to be seen, or have been seen and then need to wait for the next part of their journey, they're actually getting the support that they need to remain hydrated, if appropriate, to have a meal or some food, because obviously some patients can't and shouldn't be having something whilst they wait for the next part or next episode of their care. So we're working on a number of fronts.
Thanks, Mandy. That's really encouraging to hear, because it's the little things that count, isn't it, with patient experience, and they're the things that they raise. I know Steve wants to come in on this point. Andrew, would you like to come in next, please? And Andrew, I know you had IT problems, and when we had the Quasec report, and one of the issues was the suboptimal environment in Kilgarren, and I said you would give us an update when you came back on what's happening on that ward and the progress that's made. Thank you.
Okay, thank you, Chair, and sorry about my enforced absence through the restart of the laptop. It was feeling like a game of laptop roulette for a while there. So no, I think Mandy's probably covered everything I was going to come in on the A&E front. It was just to emphasise that there were a number of estates type work that were being worked on and programmed in to happen over the coming weeks and months that will help improve some of the environment, which whilst won't completely address the experience our patients are feeling at the moment in terms of delays, it will hopefully help make it safer and more comfortable as well, both for them and provide some assurance to the staff in that environment. In terms of Kilgarren, similarly, the estates team have been working, well, going to set up now. They've done some initial scoping work with the ward and the directorate team on some of the issues that we've identified that we would like to see addressed if possible. They're setting up a working group to sit down and plan plan a programme now of work to improve that ward area and that environment. We're optimistic there are things we can do between now and the end of March to make that feel better and bring all more parts of the ward up to the standard that the better, more recent works have brought it to in a couple of bays and one of the bathrooms it's been done. So the larger bathroom we're looking at, and in the individual patient bays, we think we can do that, providing capacity and demand allows over the next few months. We can do that before the end of March and make some real progress. We're also looking at whether going into next year there's a more fundamental refurbishment of the ward we can do, but to do that we will need to be able to decant the patients and children there to another environment, and that's the stumbling block at the moment with the pressure and demand in the system. I don't have a vacant ward. We do have a ward that we've earmarked for when we start the fire safety works as a decant ward, so we can do the fire safety works in the ward areas. So this would be part of that programme, we think, in terms of how we fit that in, and there would inevitably be some of that work that would need to be done on Kilgarren anyway. So we will just try and do what we need to do from the fire safety perspective, as well as any additional refurbishment work that we can do around the flooring and such like in that area.
Thanks, Andrew. And I know you also mentioned with me the playroom, because it's, you mentioned on the right to the child's right to play, and it's not accessible at the moment.
No, sorry, I forgot that as well. We are looking at whether we can bring in some bring in a sort of temporary demountable type facility or porter cabin type facility that we can link in some way to the ward that would provide them the playroom space, because at the moment with the surge capacity requirements and the context of RSV and respiratory viruses generally in COVID, we've lost some of that space to provide additional bed capacity for the demand that we're expecting to see.
Thanks, Andrew. And I think we'd welcome sort of an update on this. Where would that go to, you know, as it's progressing? Because this is our key children's centre for the most of West Wales, besides bronchitis, and it's really important that it improves. And it's been scrutinised by a number of committees. Is that in a planning objective?
Planning objective around
So
I mean, first I think I'd like to see the plan come back to the exec team once it's been developed.
Okay.
I think once we've got that and we've discussed it ourselves, I mean, it could go to QZF under the patient experience, or it could go to the planning committee. My tendency might be, if we've got it right, it should improve experience. So maybe it's better through QZF,
okay,
rather than just simply delivering the plan. Of course, we will supply updates on all planning objectives to the planning committee anyway.
Yeah, thank you. I think it's really, really important. And Andrew, thank you personally for going to the ward yourself, being walked around and ensuring that this action is being taken. It's much appreciated. And I know Steve wants to come in on improving A&E environments.
Yeah, well, just a thread on that last point. I guess it also what Andrew's described and the pressure on our sites and our facility. It's almost needless to say, but we're going to go on to the IMTP in a moment. The importance of building our new hospital, and I'd be really keen to ensure for the children's areas of those hospitals that they are built using the experience of children, that they're part of the design team.
Absolutely.
So we'll be hopefully a much better position going forward whilst dealing with the current facilities that we've got as best we can. It was just to mention, I've spoken to Ali about what we can do in terms of refreshment support for people who are waiting quite long times in A&E using the Cardiff and Vale initiative. So Ali is just looking at that now to see whether we can bring in maybe some dietetics support in there to support patients who are waiting for very long times on some occasions.
Thank you.
We'll bring back further on that once we've had a look at it.
Thank you. And I know from experience, it was the head dietitian who fought for that, and it actually enabled families to understand more hydration, etc., to care for their older relatives. And they were young and students, and really lifted the energy levels in A&E and enabled other A&E staff to concentrate on the more clinician side of things than the care side. So many thanks. Okay, the board's happy to accept the recommendation, and a huge thanks to the team, Mandy. It is becoming more and more sophisticated, that report, and particularly as we don't have the voice of patients directly in front of us, we do have loud and clear the voices of patients and staff right away across our organisation. So diolch for that. Thank you. Okay, we go on to the next item of the agenda, which is the IMTP, and that's Lee.
Good morning again, Chair. Thank you very much. So this is a update paper on progress with delivering the IMTP. So board will be aware that over the last 2 years, that process of producing a 3-year integrated plan, which is a statutory requirement of NHS organisations, was suspended as a result of the pandemic. Board members will also be aware that we'd not actually previously been in a position to have an IMTP approved, but as we've said in previous updates, our intention this year is to produce an approvable IMTP. But obviously a number of requirements we're going to need to meet in order to get to that point. The NHS Wales planning framework has been published since in the period between the last board update and today. It was published earlier this month, and it has confirmed that NHS organisations will be required to submit a 3-year IMTP document, integrated medium-term plan, so essentially reverting back to the normal arrangements, and that we'll be required to submit that by the 20th. The paper just gives an update on the progress with what we've been doing. So in particular, there are 2 things. The first is the work that individual services have been doing on their plans. in particular aligning their service plans with the financial and workforce plans, which has been identified as a weakness previously in our planning. And then the second aspect it updates on is the planning objectives. So we brought to the last board a review of those, or the conclusion of the review of the existing planning objectives, and board members will be familiar with our strategic objectives and the importance of our planning objectives in then developing our plans. And within the paper there's a draft of the current set of or the proposed set of planning objectives for next year and beyond. It's drafted at the moment, and the intention will be to bring that to board in January for formal approval of all aspects of the planning objectives. So happy to take any comments or questions, Chair.
Thanks, Lee. Any questions from members? Paul.
Thank you, Chair. So on page 3 of the report, Lee, you highlight that there's the first cut of submissions from directorates, etc. I was wondering, could you share with us whether there are any key issues or themes that are coming out of that which the board should be aware of at this stage? I appreciate that you're still working your way through this.
Yeah, so we've taken all the submissions and collated them and drawn up some kind of key themes. I think there are a few key questions for us to answer, given that we're still planning in a very uncertain environment, and therefore in that context planning is inherently difficult. But there are a few key aspects we're going to need to get right ahead of the IMTP submission. So one of them will be many of the things we've talked about actually today and in other board meetings. So our bed capacity planning in order to respond to COVID, but also to deal with some of the pressures that we've just talked about. We need to put some consideration into protected elective capacity, surgical capacity. We know that's going to be important as we look to recover from the pandemic. The bridging service we've talked about is another key element of the plan. And then fundamentally, the two other key aspects for us will be around our financial roadmap that we talked about through the board previously. And then secondly, our workforce plans in order to meet our ambitions. So one of the challenges for us over the coming months will be to reconcile the ambitions of the organisation and the individual services within that, because they're quite significant ambitions, quite rightly, with some of those constraints and limitations that we've got, particularly around the workforce, which the board will be familiar with. But as we develop the IMTP over the next couple of months and bring that to board in the new year, that will be a key consideration for us in what we're able to set out within that plan.
Thank you.
Thank you. Could I bring in Michael, please, and then Winston?
Thanks, Chair. Thanks, Lee. I think a couple of questions. One related to your answer to Paul's, and then one on the planning objectives themselves. The answer to Paul's question, sort of traditionally what happens is we go around this spin, and then everybody's sort of got over ambitious, and you end up with you need more staff than you started with, more money than you started with, and neither of those things are going to happen in the short term. So I was just wondering what process you're going through in order to kind of inject that realism and make sure that we end up with a balanced plan. So that's on the finances, I think, really. The second on the planning objectives, I really like the sense of we refresh them, we're adjusting them kind of in the light of kind of new developments. We add planning objectives in. What the paper's a bit quiet on is whether any drop off. The IMTP paper, the Board Assurance Framework tells us that some planning objectives have been delivered. I'd assume that some will drop off as we look to the kind of the next iteration of the IMTP.
Yeah, thank you, Michael. So on the first point, you're right, that does tend to be the challenge of developing these plans. We did have quite a set of proposals, as perhaps you'd expect. Clearly what we've asked is for people to reconcile their plans with what is likely to be affordable and achievable from a workforce point of view. So the process we're going through now is We've asked services themselves to do that level of refinement and scrutiny, and then executive team are providing then that further scrutiny and oversight for the parts of the health board that they are responsible for. And I can see Andrew's put in the chat that he and Jill are coordinating that from the ops side, which is the majority of the plans. And then finally we'll be going through an exec team scrutiny process in December to identify what we think is a priority for us. We've already set out some broad priorities to inform that, and a prioritisation framework to support that, but we're going to need to make some definitive decisions in December on what we think would be a priority for us, and that will then feature in the board paper that comes in January, and we can update some of that through board seminar discussions as well in December. On the what was your second point? Sorry.
The second point was around planning objectives. So, so I really like the fact that we refresh existing ones, we add new ones. Presumably we drop old ones off because we've been delivered. Otherwise, the whole planning objective kind of landscape becomes cumbersome.
Yeah, that's right. So in the review that we undertook in August, September, we identified a number that had been completed. So in the board paper and the detail of the board paper that was presented in September, there were a number that were marked as completed and wouldn't have a follow-on. Now a number have been completed and will have a natural follow-on because they're part of a broader theme, if you like, and that they're reflected within the document here. So absolutely, the intention is, firstly, we've got to demonstrate that we're delivering on these planning objectives as well. They're not just resetting and reviewing and producing a new list every period. This is about us delivering on those, and then when we've delivered on them and we're content with that, we can then consider either providing an updated version or moving in a different direction to prioritise something else.
Thanks, Lee. Really helpful.
Thank you.
Can I bring in Steve on the same point?
Yeah, it's just actually on both of those. So on the second point around planning objectives, there's I think a bit we need to link up with the board assurance framework. So as we complete and finish planning objectives, as Lee said, we can record the fact that we've done that through the board assurance framework, because I guess our focus will be on, has that shifted the dial at all in terms of the outcomes that we're measuring, so that we can get a sense of whether we're making the progress that actually we need to make, that the planning objectives are designed to push us towards. On the other issue around the sort of process internally, just to recognise, Lee, that yesterday I think we took a really big important step forward with Lisa's paper around the workforce model for the coming years. Essentially, I know there's a bit of work to do on just finalising the numbers, but essentially gives us the scale of the likely increase, at least for registered nurses at this point, but Lisa's now working on the other staff groups, how many more of those we're going to have next year, and that essentially sets the bar above which we can't go with any planning objectives that require additional registered nurses. So there's going to be a really strong focus, I think, now between planning and workforce to go through all of those planning objectives, to test those that are simply moving people around, which would be great, and those that are adding to the workforce, to see how much of that we can realistically do, give them a realistic assessment now about what we can do in overseas recruitment, in growing our own, and what will be on the ground next year. That will then lead to a financial answer, which my leap of faith at the moment, but I don't think it's too huge a leap of faith, is we're only going to have a certain number of staff, and that will limit our ability to spend money more than anything else. So actually the finances will probably come out largely in the right place, because we simply can't employ millions of pounds worth of people because they're not there.
Thank you, Steve. Winston.
Thank you, Chairman, and thanks, Steve, for that. Lee, this is a really good paper. I thought it was it sort of captured the process as is now. Unfortunately, when you were doing your presentation, I wasn't sure when exactly we were due to submit an IMTP. I'm just referring to the planning document which the Confederation circulated to us, which says the 15th of January, and then final plans to the Welsh Government by 28th of February. My question actually is more to do with, do you anticipate that the Welsh Government may change or add in any new priorities once they're cognizant of what happens over the winter time, which is ahead of us? Because I think what the timetable says is that NHS Wales will review and plan over winter, and I'm just wondering, If they do, then what will be our mechanisms for making sure we coordinate with other parties such as local authorities or other health boards?
Okay, thank you, Winston. So on the time scale, so we're required to submit by the 28th of February. That's the requirement. The 15th of January date is referring to the requirement on us to indicate to Welsh Government whether our intention is to submit an IMTP or not, because not every organisation will be in a position to do that. Previously, we've not been in a position to do that. So that presents us with a bit of a challenge in terms of boards and the tight sequencing of that. So I have had that discussion with the Welsh Government this week. So we're waiting for a response on the specifics of how we do that. But the date is the 28th of January in terms of submission. I'm not expecting any significant changes in terms of Welsh Government priorities. So the Minister produced a set of priorities shortly after coming into post, and the planning framework reflects and reinforces that. So I'm not expecting any significant changes. What inevitably might change is the environment with COVID in particular, and decisions relating to that. So that is a moving situation for us to handle, and will continue to be so through next year and beyond. So I guess the requirement for us in the way we develop this plan is to have the plan flexible enough, but dynamic enough, if you like, that we can respond to changes as and when that occurs.
Thank you, Lee. And the other bit about coordinating with other health boards and local authorities as well. That was the other side.
Yeah,
so it's either it's complicated enough, an integrated plan within Hywel Dda, but also obviously we've got other bodies to work with as well.
Yeah, that's right. So we're in close contact with Welsh Government themselves. First of all, that's one thing to say. So we've got regular and monthly meetings now set up with the planning team in Welsh Government to get any indications and their respective conversations going on within finance and workforce and other areas. We, as a planning community within NHS Wales, we've actually got quite close links and quite close contacts. We meet monthly as a group, and that includes Welsh Government within that and all the NHS Wales organisations. And we're in constant dialogue in between those as well. So we share quite a lot of information. We share plans as they're developing, structures, the thinking around some of these things. And one of the things I've been quite keen to do over the last couple of months is try to bring some consistency to some of our assumptions, particularly around COVID and other things. So we're moving in that general direction of trying to have an NHS Wales view, if you like, as to how we should construct these plans. So I think it's strong in that area, but developing as well. I think with regard to partner organisations, so part of our development we engage through with a number of stakeholders, and that includes then obviously through the RPB and the local authorities. And Jill might want to comment on specifics. I can see Jill's popped up on the screen there, but it is aligned to and part of the regional planning, but also a cluster planning as well. So that's another important interface for us to get right as we develop those plans.
Thank you.
Thank you, Lee. Jill, would you like to come in with a comment?
Yes, thank you. And I think that engagement with local authorities and other partners, independent contractors, is absolutely key. And I think it was my overall comment which was being raised by board members right at the beginning in terms of, the danger of having an IMTP that's so divorced from reality that it's not deliverable. And I think one of the things that we've worked really closely on with Lee's team is to make sure that this is firmly embedded within our operational system. And Andrew's reflected on the meeting we're going to have next week, but we've been having weekly conversations really around the development of the IMTP, so that we're both managing expectations, but also that the IMTP that we end up with is something that reflects the reality of the services and the operational context we're working in. And I think also testing that through with partners. There is some recent guidance out on winter preparedness as well, which will be built into our general readiness, and which also informs actually the wider sort of service readiness that we deliver through our IMTP. So we've got that close way of working. And as Lee has also picked up, cluster IMTPs also feature at the sort of bottom tier of this. So you build up from a cluster IMTP into a county level into the health board IMTP. And we look for the alignment alignment really of both Welsh Government and Health Board priorities and any other service expectations that might be there in terms of informing those sorts of elements of the plan that we would approve, so that we see that alignment to those strategic priorities. But it's actually an IMTP that reflects the reality of the context we're working in.
Thank you both. Thanks very much.
Well, thank you, Lee, and Jill, and the whole team. There's a comment from Judith in the chat bar about how clear the paper is in setting out our approach. I think this is a huge step for this organisation. The integration, as you described, with the workforce, the clarity, the reality, you know, the operational focus of what we can actually achieve is very assuring for the board. So well done, all the exec, and Lee, well done for leading this. And we look forward to getting it signed off and for our next discussions and iterations on the IMTP. Thank you. So the next item on the agenda is still with you, Lee. It's the programme business case update. Thank you.
Thank you, Chair. Yes, so this is a further update for the board on the significant programme of work that we've got underway to deliver the Health Board's strategy, Healthier Mid and West Wales. The paper provides updates on 3 key items. So the first is a programme assessment review that was undertaken during September. Secondly, an update on the programme business case itself, the development of that. And then finally, a significant milestone for us in the land identification process. So programme assessment review itself, that was organised through the Welsh Government Assurance Hub. It was a thorough process and reviewed our key documentation and interviews with key members of the team and of the Health Board. Naturally, it identified some recommendations for us, but actually, I think the board can receive some assurance that it was a positive report overall, and actually the recommendations that came out of it were not a surprise to us, and were things we were addressing. So we welcome that report and that process overall. It was very helpful to us. The programme business case itself, in the paper, it documents the specific actions that we've been taking over the last couple of months, and board will note that we are intending to present the business case for board approval in January. So we are nearing completion now with that, which is significant for us. And then finally, there's details there on the work that we've been progressing in parallel with the business case process to identify the land for the proposed new hospital. So board members will obviously be familiar with the fact that we identified a zone between Narberth and St Clair's as our a preferred optimal location for the new hospital. Within the engagement process that we did during the summer, which is the next item on the agenda, we sought nominations from the public for suitable land for that hospital. We received 4 directly from the public, and we received a further 4 from local authorities as part of that. In addition, we undertook a desktop review of possible sites in that zone, and identified a further 3, which gave us 11 possible sites. We've now gone through a shortlisting process, a technical shortlisting process during October, a workshop held in October to go through each of those sites in detail to identify their suitability, and we've now shortlisted to 5 sites within that zone for us to do some more detailed assessments on. And then other factors will also come into play in relation to access for patients and the public, and of course the clinical suitability of any particular location. So we're not expecting to select the preferred site until the summer of next year, because there's a lot of work to go between now and then, but a big milestone for us in getting to the point of identifying potential sites and going through that shortlisting. So happy to receive any questions, Chair.
Thanks, Lee. And Lee, can I ask you if there's anything you'd like to add in respect of the next paper, because we'll take them both together.
Okay, fine. Yeah, absolutely. So we're sharing with board the outcomes from the engagement process that we held in the summer. We did receive quite a lot of comments, quite specific comments. I think I'll probably acknowledge that The volume of contributions was perhaps not what we would like in an ideal fashion, but we are going through COVID, so it does, I think, raise points for us in terms of how we develop our plans around continuous engagement, and obviously there's a planning objective in relation to that. So keen to see us develop that and reach out to more parts of our communities over the next year and few years. As I mentioned, through that process, we asked for people's comments in relation to the new hospital, but fundamentally the engagement was about their experiences of COVID and the way in which services have changed as a result of that. So it's given us some valuable insight into the views of our public, and we're using that now to shape both our service planning as which links back to the IMTP conversation, but also the strategic design of our services, and in particular the comments around considerations for us in respect of the new hospital and the design of the system that would fit within.
Thank you, Lee. I'm going to open it for questions. I know Michael would like a question on the business case.
Thanks, Chair. Lee, just to say, well done on the programme assessment review. Amber rating at this stage, pretty good, I think, really. I was struck by the comment in the paragraph further down around significant step up in resource requirements, and I just, recognition that now is not the time to be frugal on resource in a programme business case. Now is the time when I think you sort of have to make sure that you are putting enough resource in to actually get it over the line in a healthy way, rather than just kind of just by lashing stuff together. So I think just to note that, I think as something that it'd be helpful if the board just kept an eye on over coming months, really.
Thanks, Michael.
Thanks, Michael. Just on that point, so in respect of the PBC itself, we're expecting to be able to complete that, and we've got the resources aligned to that. As I said, I think that comment was in particular to the OBC in the next stages beyond this, because the board to be aware, we're obviously, if we get Welsh Government endorsement for our plans, then that will mean a significant step up in our planning to move to OBC stage. So at that point we do need a significant review, which we've actually already got a first cut of that as part of the to move into that OBC stage.
Yeah, thanks. I mean, it is at that stage where people start to blink a little bit about just how much investment you have to.
Michael, you've gone on mute automatically.
Apologies. I think you're absolutely right, Lee. It's at that point organisations start to blink. So, just to urge you and encourage you to make sure that you make sure Steve gives you the right resource to get it over the line properly.
Let's try and roll over some of the underspend. Ewan.
Thanks, Chair. Yeah, thanks, Lee, for the update in terms of the very detailed report on the survey. And again, appreciate the challenges in trying to get the quantity of responses during, these kind of circumstances as well. But I think there's a lot of really good data in there, which, we can use. One kind of comment and one question. One comment is really in terms of page 19, where some of the feedback talks about now a willingness and a real kind of push by our patients and their families to look at those kind of services delivered by communities in communities. And again, it goes back to Steve's point at the start where we were talking about the Pembrokeshire example with micro enterprises. So again, I think there's evidence there now from the responses to the survey that we want to see more exploration of those local community-based services. So that's great. Page 26 talks about mental health. And I know it's coming up in one of the other papers later on the agenda, but I think the mental health of staff is a real kind of key issue, which I think perhaps we need to kind of tease out more. So I know there are things in place, but I think, I do kind of repeat myself in these meetings that whilst the frontline staff in terms of what they have endured is certainly something that we need to note and to continue to support. But I will kind of say also in terms of the behind the scenes staff, our administrators, our IT, our maintenance guys, our catering staff, our kind of hotel staff, as it were, in hotel services. I think there's a real kind of need for us to look at the mental health support for those additional members of our kind of staffing family as well. And I think that comes through in the report. And I think it's something we can look at as we go forward. But I really do welcome the report and the considerable work that's been done to undertake that report. And I think if there are ways in which, you know, other organisations within the region can help Hywel Dda to look at how we can get a bigger response rate, then, you know, I think you're knocking at an open door with many of those community-based organisations as well.
Thank you, and agree. And I think there's some rich feedback, isn't there, from the comments, and I think particularly the free text sections allow you to really get a sense of people's concerns and anxieties about some things, but also what they've found useful as a result of some of the changes that we've made through the pandemic. So I think the point about reaching different communities, so we've got as I mentioned, a planning objective in relation to continuous engagement, and the thinking that we're doing on that is how we make sure that we get proper representation from all different cross sections of our communities, and so we're starting to look at obviously hard to reach groups, but also almost a silent majority as well. So we need to kind of tap into all these different routes. So there's a piece of work underway to really understand how we would do that, and then some specific developments as well, which some members will know about in terms of working with individual groups. So in due course, I'd look to bring that back to board for an update.
Thank you. We'd welcome that, Lee. Thank you. Steve wants to come in.
It was just to add to that, Lee, and you may have referred to it and may have been referencing that in your last comment around there is some work going on through the Transformation Steering Group. I know it's been a bit quiet, but that's because there is a lot of work going on in the background. Something that Delith, I know, is involved in around particularly identifying some of those harder to reach groups, children and young people, other groups, as a sort of health board wants to listen type events. Not so much specifically about the BBC or the hospital, but actually going in without an agenda. So I'm hoping we'll bring a plan back to TSG in the new year, and that we can then share that with board. But very much a starting point for that genuine desire to be continuously engaging with everybody, not just the people who can navigate their way through some of our more formal engagement processes.
And as Anna says in the chat bar, we've got some really good data in the public health report about the inequalities and people we can target, and we can help, you know, the third sector can help us where they're trusted by those communities. It's a way in. And John asked a question about the timelines for submission of the business case. Still on track?
Yes, the feedback or the engagement process hasn't delayed our timeline. So the original timeline was earlier than January. Board members will be aware of, but we are now confident we will bring it to board in January.
Many thanks, Liam, and many thanks for the comprehensive way in which this is being done and the inclusive way. And we're looking forward to hearing more detail about the public panel or the majority of public and how they are going to be recruited. And again, it's the same principles about not you know, getting real voices, not that other people aren't real voices, but not the same all the time. So thank you. So I'm going to give the board a 5-minute break, so we come back promptly, and then we'll go into the public health report. Many thanks. Croeso, welcome back. We're going now straight into the Director of Public Health annual report, and welcome, Joe. I know you're going to take this.
Apologies, brilliant. Thank you, Chair. In the interest of time, I'll just really briefly go through the headline stats, and I just wanted to mention a couple of successes locally that we've had during the pandemic, and then some plans for the coming months. So the report itself starts off with a really bold statement. Actually, health inequalities are unfair and they're avoidable. The causes of health inequalities are complex, and we know that those living in our poorest neighbourhoods die on average around 4.5 years earlier than those in more affluent areas, and that healthy life expectancy in Hywel Dda, there is a difference of just over 12 years between those living in our poorest areas and those living in our most affluent. Across Wales, that difference is actually even more stark at 18 years. Health inequalities are complex. It's difficult to impact on them, and it's difficult to reduce them. And historically, both locally and across Wales, we've focused both on different aspects of the work that we do and trying to build equality impact assessments into that, and also linking in with teams nationally, just to make sure that in everything we do, we're considering health inequalities, and we're making sure that we are targeting those most at risk. COVID has given us some unique opportunities actually to do something, work a little bit differently and do things a little bit differently, to really focus in on health inequalities. And I just want to talk about one example really briefly of that, and that's around our vaccine equity group. This is a group that's been led by a brand new role in the health board, a senior public health practitioner who his entire role is just focused on vaccines, and the majority of that role is actually focused on vaccine equity. He's pulled together a vaccine equity group, ensuring that we've got the right people around the table. We've got representation from the BAME communities, from travelling communities, from our homeless communities, from our most deprived areas in Wales, from our least deprived areas in Wales. It's got all the right people around the table, and really put a lot of focus into just making sure that that vaccine equity and that group works effectively, and that our uptake is equalled out, if we can use that as a term, across the area. Key to that group has been our community outreach workers, who've been funded through prevention and early years money, and we're looking to mainstream that and ensure that they are able to expand that team and continue to work in this way going forward. But I think what this has taught us is we've had occasions where we've actually had to send vaccine teams out to immunise. You know, they've had to travel long distances to immunise maybe 2 people from a certain community, and put a lot of time and a lot of effort into doing that. But that is what we've had to do to make a real tangible difference. And this topic-based way of working, we have seen actual impacts from doing this. We've seen uptake in those 10. We've got 10 communities who live in the most deprived area, live in the 10% most deprived areas of Wales, 10 communities in Hywel Dda. We've put a real focus in there. We've gone out in the van with our fire service, and we've given vaccines out in those communities, and we've seen tangible differences. Working in this topic-based way has given us that impact, and it gives us an opportunity going forward to say that is something that we can really put some efforts into in other areas, maybe in our smoking, in obesity, and in other specific public health topics. We've got the strategy we need, we've got the Wellbeing of Future Generations Act, we've got the outcomes of the wellbeing assessments, and we've got a real opportunity to move forward, to really move on some of the inequalities agendas. The other one bit that I really wanted to mention was around carers. We during the pandemic, unpaid carers have come forward, and I self-identified because self-identifying as an unpaid carer made you eligible for a COVID vaccine. So lots of people who previously maybe didn't consider themselves as unpaid carers, but were doing that role, but hadn't identified themselves to us and hadn't applied for any support with us, have come forward during the pandemic, and we've seen a 64% increase in the number of unpaid carers that we've got. So with that knowledge and with that new knowledge going forward, you know, we can really work to support that group. So those were the two areas I just really wanted to highlight, and I'm happy to answer any questions around the report then.
Many thanks, Jo. So open to questions. Maynard.
Thank you, Chair. An excellent, informative, and a very challenging report when you put it down in stark terms. But I was wondering, how are we as a health board turning the information that this report provides into actions? You've given us some really good examples, but I'm thinking in terms of a previous paper on planning objectives and anything that we can do to make sure that we are addressing those as a health board.
So I can speak from the Public Health Directorate side. I mean, I know the Health Board has given us the 20-year strategy actually gives us a really good platform, I think, to start talking about health inequalities in a really serious way. We've got some specific planning objectives around this agenda. One of those is we're committed to, it's towards the end of next year, we will arrange a facilitated discussion with Board to agree the approach to health inequalities going forward, and prior to that discussion we will build on this report and build on the work done to fully understand where those inequalities have, how COVID has changed those inequalities across the system, and how we can best work with our communities to try and reduce health inequalities going forward. We do have a bit of a unique opportunity as well at the moment with the local public health teams are moving in to be employed by the health boards. That's a change which is going to happen over the next year or so, and that will mean that we've got a skill set which will be directly employed by the health board then, and we'll be able to focus from a Hywel Dda perspective on those aims in our strategy and not be potentially pulled in other directions. And I think that as a team, the main focus is on reducing health inequalities. They've got the skills and the drive to do that. I also think as part of the IMTP, we're putting in several bids for several different posts and some investment into different areas. But this topic-based approach, that is something that we potentially haven't had opportunity to do before, because it takes a lot of effort to really go for targeted approaches in different areas. This is the time that we can really start talking about that, and we can really seriously try and make that happen.
Thanks, Jo.
Yeah, I know Steve would also like to come in on the same point.
Yeah, a really good question made on this. And as Jo said, in a specific planning objective actually about the board becoming coalescing around what it is we want to achieve here. I think probably what I would say, just in context of that, as Jo sort of alluded to or already said, reducing health inequalities is really tough. Actually, it takes really concerted effort and resources to make it happen. I don't think it's a great reflection generally on the UK that probably our health inequalities are very little different than they were when the first report came out back in 1950. Was that the Black Report? I can't remember which one it was now. And actually it demonstrated there's been so little progress on this UK-wide for many years. But it is complex how you address it, and the almost like the philosophical approach that we wish to take, which is why I think the board needs to debate it about how what you do to bring the bottom quartiles up and what happens to the top quartiles, for example. There's a set of real issues there that I would like the board really to think about how we approach. However, in the meantime, as well as that discussion, we're doing a lot of things in our planning objectives which may not look obviously like they're dealing with health inequalities, but are probably things that we feel are going to help us move in the right direction. So things like the foundational economy work, the social value work that Hugh's leading on, the locality development plans, the stuff that Lisa's doing around apprentices. We kind of know all of those things are going to contribute something to this, But what we need then alongside that is probably to bring all of those threads together with this board discussion, and then make a really concerted effort to ensure that A, we filled any gaps, and B, that we are putting the resource behind it. That will be a huge challenge, and one that will reverse 50 years of not having done it. And I think if West Wales can do it, then we absolutely will. So I think, you know, real opportunity here for us to really take this. I think the other thing I would just mention is we probably need to ensure that we've got as real a time measure of health inequalities in our area as possible to feed into the board assurance framework, so that we can see the actions we're taking, are they moving the dial? And that's probably something we'll pick up in our discussion that the board secretary referred to around what should our measures be going forward. So quite an exciting agenda for us, I think, but we are only at the start of it. But that's not to say I don't think we're already doing some really good work.
Thank you, Steve. I'm going to bring in Delen.
Diolch, Joe. I'm really interested in the inequalities for our communities, especially our rural communities with very small numbers of population. And I really welcome this report, and I welcome the way that you have delivered vaccines, for example, with a mobile provision. So how will you really address that inequality for our children, young people and our families living in these very small pockets of communities? And also they haven't got that access to our services due to travel infrastructure and access to food that's at a reasonable cost, because they have to travel sometimes on the one only bus that goes once a day to a town, and then that additional cost really exacerbates their feelings of inequality. So can you please describe to me how you would try and address that inequality, please?
No, absolutely. I think, I mean, you've highlighted what the exact challenges are. Really, we've got 10 communities across Hywel Dda in particular who live in those 10% most deprived areas in Wales, and they are the people who don't have access to be able to take themselves to those services as needed. I think the work that we've done around vaccine equity has highlighted that when we put a concerted effort into a specific topic and making access equitable for everybody in one particular area, we can make real inroads for real people. And I think the challenge around that is the effort and the time and the real concerted effort that takes for every person in every community affected there. We do have opportunity now because we've seen it work with vaccines, and we've seen that approach work. We need to link in with everything that's already going on. You know we have lots of programmes. We've got the Flying Start programmes. We've got lots of work going on already across the Health Board. Lots of really good work going on to try and ensure that there's equity of access, and that we're tackling some of these big issues. But I think that certainly taking a real topic-based approach going forward and linking this all in with I know there's big work going on with the social model of health work at the moment, just making sure that everything comes together. And we take one of the lines that we've used a lot with the vaccine programme is leave nobody behind. I think that needs to be our line actually with everything around health inequalities going forward. We need to be the health board that leaves no one behind. And they're big statements and they're really difficult to do, and it's making those statements, actually mean something for real people. And we are at a point where I think we've now got the tools and we've got a model that's going to allow us to at least start to make those inroads.
Thank you, Jo. I'm going to bring in Steve, please, and then Michael. Sorry, Paul, and then Michael. Sorry, Steve. We lost Paul. Grant.
Sorry, it's me. I thought you would start Steve next. Sorry. Yeah, the question I put in the chat bar was about how we make sure that the identification of unpaid carers is not a one-off caused by the incentive of getting a vaccine, because clearly that's a group that will change over time. So how do we address the issue of those unpaid carers continuing to come forward to identify themselves so that we can provide them with support?
Yeah, so what we've done is we've worked with our lead in this area, Anna Bwrdd, and she's ensured that there's more kind of promotion on our website, and we've put more information out to ensure that unpaid carers know how to identify themselves. They've streamlined that process, so there is an online form that you can just fill in now. And at all of our mass vaccination centres, we've got big banners now, just to say, you know, if you are an unpaid carer, because we're obviously vaccinating and we're giving boosters to everybody over 40 now, so we've got people coming through who will you know, potentially see these banners, and it's got all the information there on how they can identify themselves. You're absolutely right. Over time, you know, at the moment there's a big drive, isn't there? You know, it's International Carers Day today, and we know that people know how to identify themselves, and we've done a big drive on that, and we've had people come forward. I think we just need to not lose the momentum there, and it needs to become something that's very normal for people, because we don't know what we don't know. And we didn't know that we had this massive, you know, we knew we had people who were unpaid carers and hadn't identified themselves. We didn't know the scale of the problem. We've had around 5,000 new unpaid carers come forward over the last 18 months and identify themselves. I don't know how many more we've got, and I don't know how many more people are out there, you know, not accessing some of the help that they could be accessing. I think key to this, though, is not losing the momentum and making sure it stays on agendas, and that we're regularly putting out additional information to just make sure that people know how to access the help that's available.
So if I could just sort of link this back to the discussion we had earlier about the issue about people being effectively stuck in hospital, and many of those people would probably be dependent upon unpaid carers, and so the provision to unpaid carers to help prevent people ending up in hospital and to help people come out of hospital, so to make sure that those people are properly supported is a benefit for all, not just the individuals concerned.
Yeah, I think when you invest in unpaid carers, you're investing in two people, aren't you? The cared for and the carer themselves, and helping health of both mental health and physical health of both. Then.
Thank you, Michael.
Thanks, Chair. And thanks for the report. Really helpful, very clear actually, and as Maynard says, quite a sobering read. So addressing public health inequalities is one of those wicked issues that, you know, is kind of everyone in the 21st century is trying to address. And I noted Steve's comment about doing what we can do, but we don't work in isolation here. We can only move the dial a little bit with the whatever lens we've got on the problem. So I just wondered what your view was about whether the other actors and agents in this space recognise the situation, but more importantly, probably recognise what needs to be done and whether or not they're engaged on it.
Yeah, I don't know, Phil, did you want to come in with some of the work that you've been doing, or do you want me to? Shall I start? I say, you know, to start the answer to that question, there is a lot going on with a lot of different agencies across, like you say, across Wales to try and address the issue of inequalities. There are national groups run by Welsh Government. There are national groups run by Public Health Wales. We've fed in, you know, even just on the vaccine equity issues, we've fed into 3 or 4 national groups that have been set up to deal with this. I think key for me is that actually we're making sure that we're addressing what needs addressing locally, because what we found actually is some of the issues that we've got locally around rurality, some of the issues in terms of access, they're not the same as everywhere across Wales, and bringing together all the local partners that we can has proved really successful in terms of our vaccine equity work. So replicating that for me is the on the ground stuff that we can do locally, which in my view will make a difference. There are lots of bigger conversations going on that I know will address this in different ways. Phil.
Yeah, thanks, Joe. Are you happy for me to come in, Chair, briefly? Thank you. My My point was, in fact, the Chief Exec's made most of the points that I was going to make about the constellation of planning objectives. My points then are that the gap in healthy life expectancy has actually widened. As Rosa said, it was 10 years when we presented our strategy in 2018, and now we're presenting data of 12.2 years. So that is of concern to us. All of the feedback from the work on the social model of health planning objective suggests that it has really pressed us to have a focus on health inequalities. That's been the biggest overwhelming feedback from all of the different partners, and we're trying to speak to people from who represent every one of the social determinants of health, and so that is the feedback from all of our partners. And what's also become obvious is that individual partners are undertaking specific pieces of work to tackle the social determinants of health and try to improve health inequalities. For example, some great work in Carmarthenshire Local Authority and Teesha Ward in Llanelli, which I think we could be more involved in. So I think that the work we do tackling health inequalities, because it's the social determinants of health, will need to be with our partners, and I think our partners recognise it, but want us to be more part of their actions than we currently are. And I think with the constellation of planning objectives that we have in place, I think it'll drive us to do that in the next couple of years.
Yeah, thanks for that. I suppose if I may come back from just a moment, Chair, it just strikes me that we're sort of looking at this as the health board deals with the consequences of public health inequality, but actually fixing public health inequality sits within an economic portfolio, an education portfolio, an early years portfolio. And I suppose I was wondering, where are the solutions to those? Otherwise, we'll constantly be trying to kind of clean up the consequences of not addressing the whatever the social determinants are.
Yeah, just to come back in on this one, then I think that while the social determinants aren't within our gift to change necessarily, although you know, when you change people's lives in some ways, you can influence that. The impact that has on health inequalities is at least partially within our gift, and ensuring that people have the best chance to live as healthy a lifestyle as they can, looking after both their mental well-being, their physical health, and looking after them through that life course, making sure that we're signposting where we can to appropriate help that they can get, and doing more than just the responsive health side. You know, we're doing that preventative work and trying to change the narrative to make sure that actually people want to live the healthiest and best lives that they can. That is within our gift, and I think that is where, from the local public health team end, you know, that's where our focus really needs to be. Totally appreciating that actually it's a far wider and a far more difficult discussion to change the actual causes that feed into those inequalities to begin with.
Thanks, Joe, and thanks, Michael, and thanks to Phil. And there's a lot of comments in the chat bar, and Hugh, thanks for offering to come in, because it's all interconnected. We've got lots of planning objectives. We've got the wider impact of all of our public partners in our communities. We've got the social value work, and we've got the data within this report, which is really valuable data, and that topic approach that you have been talking about, Joe. What I would suggest is, with our partners, let's look in the spring, because at the moment, operationally, we have really got our heads down to get through the winter, but let's draw it together at a sort of a summit where we can all discuss and have a kind of a roundtable think tank. I know, Jonathan, you mentioned the PSBs, but perhaps we can go into a bit more detail with our key partners together and what we can do as a health board, because we do have the levers in some of these areas, and all the other evidence that we're gathering at the moment, even, you know, looking at when we recruit apprentices, do we recruit through that lens of inequality, or is it more open than that? Lots of different things that we can approach. So if I ask that we do that, we'll plan that spring, you know, mid-spring, whenever we've got that little bit of space now with all the work that's going on, to lift our heads up and look to the future about perhaps maybe how we steer the boat in a different way because of that. So thank you everybody for that report, and thank you for the debate and all the ideas, and I can sense an appetite to do more in this space and draw together what we're already doing. Can I also give a thanks on behalf of the board to our Director of Public Health, Ros, for everything that she's done in relation to the vaccination campaign and in relation to our strategy for public health and this particular report as well. So thanks, Ros. So as you know, we're getting tight for time. So again, I'll reiterate, quick question, you know, succinct questions, succinct answers, please. So if we, I know it's hard, but I'm really begging you this time. So thank you. Next item on the agenda is the delivering our recovery plan.
Sorry, I was just laughing at Mr. Newman's comment about mentioning boats and getting me started. It's in my head. But thank you, Shay. And in all seriousness, this report does bring us back to the kind of here and now and the pressures we're facing. I think if you read this alongside what we've just talked about, the patient experience report, and indeed what's coming in the integrated performance report, both of those things I think put in much more clear terms the pressure the system's under and the consequences that that's having, both on those measures of performance, but also on the experience of our patients. Having said that, our current situation today, and Andrew will be able to give a more immediate update, but certainly when we met yesterday as a team, is the situation is pretty similar to that which I wrote in the report about 10 days ago, which in some ways is a positive reflection of the fact that the system does feel a little more stable than it has done, albeit stable at relatively high levels of escalation and pressure. The discussion we had yesterday in relation to where the hospitals are, I think the Director of Operations was describing that the teams felt that the hospitals were hovering just inside red rather than being deeply red in their escalation status. So some small improvement. And I know this morning while we've been in board meeting, the 10 o'clock update saying that things are feeling a little better again today. So I don't want to overstate that because we still are under extreme pressure. But I think we're seeing in a number of areas now maybe some very small improvements. We heard yesterday in primary care there's been a slight reduction in the number of GP practices who are at level 4, and that we've got slightly more accessibility in care home beds than we've had. Was really delighted yesterday to hear that our current outbreaks had all been closed. We've got no outbreaks that are active, and the Director of Nursing just gave an update on the careful considerations we're giving for visitors restarting, given the Christmas period. I would say as well that in some parts of the system it probably still feels extremely pressured, particularly in ICU, and we're seeing that pressure every day. But there's a lot of things that are coming together that I think are helping with that. We talked about bridging service earlier and some of the successes from our local authority colleagues in domiciliary care, just helping to turn the dial back slightly. The Lissa-Bryn expansion in beds now being open in Carmarthenshire and the Amman Valley, beds starting to open. In terms of infections, I've just checked the numbers today. We were at, I think, around 473 when I wrote the paper. We're at pretty much the same level today, so another stable picture, albeit at a higher rate than we may like. It was at 471, I believe, this morning. What I can take in positives from that is that we haven't seen the bounce back in infections in our younger age groups that we may have expected following half term. It should have come through by now. Indeed, our rates for 25 and unders, which includes that cohort, has dropped from over 1,200 per 100,000 down to about 630. That's the latest figure I've got. And more positively than that, even the numbers getting infected in the older age groups, which who of course are more at risk of hospitalisation, has also started to reduce again, and as at Monday we were at 234 per 100,000, so it fallen slightly further from my written report. It is likely that vaccines are having are playing a significant part in this, as well as, of course, our public continuing to observe social distancing, mask wearing, and so on, which is also helping. And that this is happening despite the fact that weather is getting cooler, and we're existing in a world where there are relatively few restrictions. I think is positive. On vaccinations, you'll see the numbers in the report. That number today stands at 687,000, so it's gone up significantly even since I wrote the report. Our boosters now stand at 97,820, which I think is probably 1 in 4 of our total population has now had a booster. It has been challenging to roll this out, particularly as the chair mentioned in her update earlier, that we're dealing with Pfizer and Moderna, Pfizer particularly being much more difficult to handle, and of course not being able to use the primary care practice route that we did previously. That really got our vaccines right out into our local communities. That has created some challenges, and the team continues to look for solutions, are really open to feedback, very grateful to our CHC colleagues who have been able to feedback some things that we've been able to attend to, and we keep trying to maximise our uptake by amending our approach. As already mentioned, the boosters have now extended to our 40s and overs, and we'll be adding those on to the end of our booster campaign effectively, because we're largely at around 6 months now, which is the JCVI interval, plus or minus 2 weeks. It can vary a little, and we do have we can see a bit of a larger cohort coming through who are at the 23 to 24 week period that are going to give us a couple of challenges, but with the team are optimistic we'll get through that quickly and be able to largely maintain that 6-month window. We've also had second doses authorised for 16 to 17-year-olds, and the vaccination team, the last time I spoke to them earlier in the week, were building in that capacity into our plans. Our COVID patients in hospital now stand at, this was the dashboard on Monday, 73, considerably lower than the peak that we've recently experienced. However, as I say, they're still relatively high numbers in our ICUs. Of course, given the scale and size and layouts of our ICUs, that does give us some challenges, particularly with planned care restart, where we may need those ICU beds. And I guess the other thing to mention in relation to that is this demonstrates that this disease is still causing significant harm to some people. So again, reiterating to our public that getting vaccinated is really important. We've had the update on bridging and the Amman Valley beds earlier, so I won't go through them again. There was a whole set of quite complex gold discussions, particularly around enhanced pay rates. We're now at the point we may need to have a further gold, possibly tomorrow, just to extend our current arrangements a little further, but Welsh Government have now published their advance notices and they're in the process of being implemented. I would say, again, a testament, I think, to our teams, Lisa's team in particular. The Welsh Government scheme, they looked at our evaluation, because I believe we were the only health board in Wales who evaluated the impact that we were having with the enhanced pay rates, and they used that in their formulation of the advance notices. So actually we are pretty much in line with that, even though they haven't yet been implemented nationally. So that's really positive. I would just recognise though that the evaluation was quite difficult to do and wasn't conclusive about whether it's worked or not, because we don't know what would have happened without it and whether things would have been worse in terms of staffing. So it is quite a difficult thing to get right, but it felt like the right thing to do, both to support rota filling, but also to show our staff that we were absolutely supporting them in doing what they needed to do. So I'm looking for ratification of those various goal decisions today, as we have done previously, and in time the enhanced pay will be superseded by the national scheme, and if we do need to extend that, as I say, we'll have a quick goal to do that this week or next. On other issues, you can see, and we've mentioned it earlier, Alison mentioned it earlier, but the restart of our work in relation to stroke services, really important. I think there's a renewed sense of urgency around this now, and of course we've got the Swansea Bay element to that as well, and it was good to catch up with them yesterday. And I've given some specific updates on a couple of the planning objectives, although recognising that most of them went to the planning committee recently, and actually the board assurance framework also provided further details on where we were in overall terms. So I'm hoping particularly around the waiting list support service, which is so important, that will now start to really gather pace. You can see that there's a lot of action now coming forward for the Q3, Q4 period. So I'm happy to take any questions.
Thank you, Stephen, and Andrew's happy to come in as needed as well. Questions, please. I think that's Judith, please. And then Maynard.
Thank you, Chair. My question actually is relating to ongoing recovery, but it's more a question about the things that aren't there. We talk about planned care, but there's no mention of any of the waiting lists within mental health. I'm particularly thinking about neurodevelopmental waiting lists and also waiting lists for other aspects of the CAM service, which are planned care. I know Welsh Government funding hasn't particularly targeted those, but there is funding that's come into those services from Welsh Government. So I'd really just like some sort of not detailed information, but just an assurance that that is part of the discussion, and maybe whether some of that could feature in future updates.
Yes, of course. Andrew might want to come in, but yeah, of course, Judith, apologies that we hadn't covered it in this paper. We have just signed off our slide deck to support our joint executive team meeting with Welsh Government, which is happening next Wednesday. There is actually a full update on mental health, LD, and indeed cancer services and other services in that, which we will share with all board members. I think they're being finalised today, so you should get them in your inbox, but we will ensure it's then covered in public board papers going forward.
Great, thank you, Steve. Thank you.
Andrew, did you want to come in on that at all?
And just to give some assurance as well, that in terms of the recovery work stream and programme, we've got the SRO for that. It is clear that mental health and LD recovery, is the specific example, is included as part of that oversight role as well. It's not just the planned care actions. I think, as you said, the challenge has been a lot of the requests for information and schemes has focused on planned care in terms of the money that's been made available, and the money for mental health has gone for a separate route and process. But we'll make sure we tidy that up just as a routine matter of business, Judith.
Thank you.
Maynard.
Thanks, Chair. Andrew, I think this question's specifically for you. On Appendix A, in terms of the recovery actions and the outsourcing of work, we had a discussion in SDOD committee about this, and there was some lack of uptick from the population in terms of travelling for treatment. Just wondering if the situation has improved.
No, that still remains a challenge in terms of there's a choice being offered to patients of an earlier treatment alternative provider, and particularly those providers that are further away, that's proving more of a challenge in terms of uptake. What that will mean is we'll just keep working through the waiting list, so the overall numbers will reduce. But as we discussed in the committee, that may mean, as naturally happens when we outsource anyway, normally there may be some it may mean some patients get treated slightly out of turn on the basis of those choices. I think the other thing that we have just explored in the last couple of weeks, or 2 or 3 weeks even, since we were at committee, is that there is a new provider for ophthalmology in Bwrdd that we're exploring the potential for a contract with them between now and March, and that will actually probably make that will help mitigate and manage some of the risk in terms of the remaining spend that we've said we're wanting to make within this financial year.
Thanks.
Can I bring in Mansell, please?
Yes, thank you, Chair. Just a quick one, really, on this waiting list initiatives going out of area. Can the board give assurance that patients who turn down going to Gloucester or Bristol or whatever are not disadvantaged in any way in relation to their place on the waiting list?
Yeah, no, Mansell, thank you for the question. No, the patients won't be disadvantaged. We'll continue to treat in order of clinical priority and urgency. I think the challenge we've obviously got is, and one of the reasons for the outsourcing, is there are significant numbers of routine patients waiting, and routine activity locally within our core capacity at the moment is the aspect that we're most challenged on. So we are being clear with patients that if they aren't able to take the option, don't feel they want to take that option, that may lead to a longer wait because they could get treated sooner if they did go to one of these facilities. But in terms of the waiting list, it doesn't affect their position.
Thank you.
Ms. Andrew, if I bring in.
Andrew said it, so I want to be clear, it doesn't change their position on the waiting list.
Thank you. So the board's happy to ratify the Girl Command Group decisions and note the wider update. And as John says in the message, this paper demonstrates the vast amount of work teams are undertaking to try and expedite patients' access and required care and treatment and reducing waiting time. And I just want to re-emphasise that we are absolutely committed to doing everything that we can to reduce waiting and enable people to access the care at the same time as treating those people who are currently very ill. So well done, everybody. And I know it's very pressurised, and that is the whole of our workforce out there are doing everything that they can. So Diolch, thank you. So we're now going on to the Integrated Winter Resilience Plan. And that's Andrew.
Sorry, apologies, Chair. I wasn't sure if we were going through all of these individual papers, so I was under the way they might be attached as an appendix to Steve's. But the Integrated Winter Resilience Plan. We have discussed that in committee and in board seminar in the last month or so. It builds on the integrated plan that we had in place last winter and has tried to focus on the fact that we wanted a more sustainable approach going through the year. So rather than a number of schemes that we would stand up for 5 or 6 months that we then traditionally have struggled to staff or implement and put in place in the timeframes, we've maintained those through the year as part of our ongoing plan for delivering unscheduled care improvement. It brings together the plan, therefore, the kind of regional aspects and the transformation fund and integrated ICF funded initiatives, as well as the local improvement plans that we've got internally around urgent emergency care, picking up primary triage, physician triage of the ambulance stack, same day emergency care and urgent primary care. So it brings all of that together. I think as well as some of the additional capacity options that we're putting in place that we've already discussed today. I think it's worth noting, and we probably should note, that even with a plan and as confident as we may be in the plan we've got to deliver the best we can in the circumstances, it won't escape the fact that we are expecting it to be a difficult winter given the pattern of activity and demand we've seen over the last 2 or 3 months, and there's no reason to think that that will change. We hope that the actions and expect that the actions that we're putting in place will ease some of that, but I do still expect that we'll have some difficult moments in terms of delays and the demand that we see, because we would normally see that through winter, but some of the context at the moment exacerbates that. So I wouldn't want to give the impression that the plan we've got means that we'll see a return to what might be considered a more normal service for us locally. We'll still see the pressures, I think, that we've seen just because of the environment in which we're operating.
Many
I have
thanks,
to take any questions, Joe.
Many thanks. Are there any questions on this? And thank you for the caveats as well, Andrew. They're realistic and we do fully understand. And I know everyone will do the best they can. Okay, the board happy to take assurance from the progress being made in regards to winter preparedness. Jill, did you want to come in on this, or you come for the next speaker?
No, it's the next speaker. Thank you.
Thank you very much, Andrew, and everybody. Jill is accessing primary care.
Yes, thank you, and noting the need for brevity, Chair, but I just wanted to emphasise the importance of this paper actually linking into the operational discussions that we've had earlier in the board. I want to start off by saying a considerably large thank you to all of our primary care contractor professions for the work that they've continued to do. We know even without COVID, over 90% of all access in terms of our services is through our primary care contractors. But I also want to thank our patients and the public because they've also had to adjust the way in which they access services. And I think that relationship with your primary care professional is exceedingly important. And we know that when there are challenges in terms of being able to access those primary care services, it can have an adverse impact on other parts of our system, as we've seen, and people may resort to A&E, etc. But I know that there's been increasing focus in recent weeks as a consequence of increased media attention to primary care as we try to reset services. And we've also noted an increase in perhaps public frustration around some challenges in being able to access the type of services that people would like. And I think there has been a focus on the return to face-to-face consultation in general practice. But we also know equally, and it was reflected in the engagement report that the Director of Planning presented, that carers have also welcomed actually the alternative options in terms of being able to consult with general practice, giving them a greater flexibility in terms of their caring responsibilities and being able to access appointments. So I think the paper sets out the sort of changes that we've seen through our primary care services. There are different points in the system for all of the contracted professions. You'll note that dental services, for example, remains in an amber phase, but are gradually increasing the number of routine appointments that they're able to offer. And this is predominantly because of the nature of dental practice work includes a lot of aerosol generated procedures. So again, more challenges in terms of that. But primary care, like the rest of the system, have experienced, particularly in this last wave, the impact of staff shortages, staff sickness, and also the demand on those services means that we've seen an increased number of closures, short-term closures in community pharmacies, for example. But I think overall the system is trying to restart. We want to make sure that our public, our patients, have access to the right professional at the right time. The Minister has also confirmed that the development of technology that we've seen throughout COVID will remain. So you will see that continued mix of e-consult, of telephone triage, but face-to-face appointments where clinically appropriate. So I wanted to commend this paper to you to set out the enormous amount of work that continues to be done through primary care, and to thank our public for their way in adjusting to the sort of changed way of consultation with primary care, but also recognising the challenges and frustrations that some individuals have had in terms of what they perceive to be getting timely access. So, Chair, I'm happy to take questions, but primary care is an enormous part of the whole system approach to services, and we want to make sure that we get that access right for our public.
Many thanks, Jill. Can I open it to questions? Jill, can I say I've on behalf of the board, I really welcome us having this report to the board. Absolutely, it's the foundation and the biggest supplier of healthcare in West Wales, and I'd like to see these reports perhaps more frequently. One question I have is there is reference to the ARCUS doing a demand and capacity management exercise at both practice and cluster level, which will be reported to the contract review group. How will it come to a committee in the health board system so that we can also have the information and scrutinise it? Sorry, you're on mute.
Sorry, we'll bring that through the right board subcommittee, Chair, probably through the strategic development. Sorry, I got the wrong name. The planning committee. Yes.
Let's keep it planning and people. It's simpler.
But also, I'm sure we do talk about access within the quality committee as well, because again, people feel that some of the quality of their care may be compromised by their inability to access services. So anything that's relevant for that committee will also be picked up through that route.
Thank you. It also refers in the paper that we've seen 5% more patients in our health board compared to the All Wales average. Is that because of the demographics here, the older population?
Yeah, we're looking into that, but I think as Joe's reflected in the Director of Public Health report, we have a number of communities that have a level of deprivation that is exceptional, and I think people have felt that their need to access services coming through the system as demands increased does reflect that that need within the population.
Many thanks. Maynard, you popped up on the screen. Was that for a question? No. Oh,
no,
okay.
No, Chair.
Okay, thank you. It was lovely to see you anyway. Thank you very much. Jill, many thanks for this report. As I say, I'd like to see them more frequently because I don't think we're cited as much as we should be on primary care and community care. You know, they're very, very important. And thank you to the whole team. And as you said, to our general practitioner colleagues out there and to our public. So many thanks. If we go on to the next report, then it's nurse staffing levels, and that's Mandy.
Thank you, Chair. I will keep it very brief because I think the level of detail within the paper speaks for itself. I think probably I do need to say a huge thank you to all of our nurses and midwives across the organisation in both our inpatient and community services, particularly for their flexibility that they've shown during the last 18-20 months. Because without them being prepared to move, be redeployed, and we've heard about the redeployment throughout all of the papers. In fact, there's been reference to how our staff have been so flexible. We wouldn't have been able to sustain continuity and safe care throughout all of our services. And I think what the report demonstrates, because we do have an extremely robust process in place, as you will have heard at the last time that we looked at the 3-year report, because this is my annual report that I am required to bring to board to demonstrate that we are meeting the requirements of the Act in terms of the calculation. You will see that there is a tremendous amount of change and movement in all of our wards in all of our services. What the report also calls out, and it's something that we as an executive team have looked at very recently, is the significant level of acuity and the increasing acuity that we've seen in the majority of our clinical areas. And that obviously has a direct impact upon the way we staff our wards to make sure that patients' needs are met in a safe and timely way. What you will see is that for the first time I've also got the data and the calculations associated with paediatrics, because that became part of the Act from the 1st of October. And interestingly, what you will see as part of the work that we're doing on the team around the patient, every ward sister and senior nurse across the organisation has engaged with me personally to talk about what they need for to meet the care needs of their patients. And you will see that the calculations on this occasion have shown that we are planning to see a reduction of 10.9 whole-time equivalent RNs, but with an increase of 48.44 whole-time equivalent healthcare support workers. And that directly links to the conversations that we're having about the team around the patient model, so that we focus on the needs of individual patients and the outcomes that they require. You'll also see in the paediatric wards that the calculations have meant that there's 1.49 whole-time equivalent less RN, the requirement, but an increase of 10.43 healthcare support workers. That's not going to come without its challenges in terms of the increase in capacity required in our healthcare support worker workforce. But it does reflect the different types of roles that we want to and need to introduce within the workforce as well. So I will leave it there, but I just wanted to call out those few points. I'm happy to take any questions.
Many thanks, Mandy. Are there any questions from board members? Mandy, I have a simple question, if I may, and it's about, you know, looking at everything through the lens of our ability to recruit. So the calculations have been done. It's great to see, you know, the different types of nursing staff, which apply to the needs of that particular patient. How optimistic are you that we will go forward to recruit these staff?
So I think there's a couple of things in this. One is that we are pushing the boundary a little bit around the advanced practitioner role that is fits within the whole-time equivalent that we've identified for the healthcare support workers. And there's already an active recruitment campaign, and we've been successful in attracting some external assistant practitioners into the organisation. Not quite in the numbers that we need, but we are moving forward. We've also got our nursing apprentices that will be moving into a different level of role from the role that they're currently working in, and they can be part of the solution to help us in this team around the patient model. Plus as well work that we're doing in terms of developing and educating those that want to go on into potentially registered nursing roles, again to recruit into the advanced practitioner role. The piece around the registered nurse, and Lisa may want to come in and answer some and talk about some of the work that they're doing. And in fact, we talked about it as an executive team yesterday around looking at potential overseas recruitment to help us fill some of our gaps. Looking at how we advertise our roles, looking at the career structure that we're able to offer within the organisation. So I'm under no illusions that this is a quick fix, but certainly we need to identify the numbers of registrants that we need so that we can ensure that we're workforce planning effectively. And that's why the strengthening of the healthcare support worker role, the introduction of the advanced practitioner in more areas, and the absolute drive around the use of the delegation framework is going to help us move forward.
Many thanks, Mandy. John's got a comment there about welcome the redesign of the nursing workforce to reflect the patient needs. Many thanks. I'm sure the overseas recruitment is going to be considered at the people committee in any event. So we'll leave that to them to John's group to scrutinise. Are the board happy to accept the recommendation? Yeah. Mandy, I know it's difficult to do, but beyond that, you know, the nursing workforce have been incredibly flexible, at great cost sometimes to themselves, going into areas which cause them fear, leaving their workmates, etc., being redeployed, have been so dedicated and given so much of themselves professionally and personally over the last 20 months. So a massive thank you to you as the leader of the nursing workforce and to all our nurses out there. And thank you for this paper as well.
Thank you.
Next item on the agenda is the corporate risk register.
Yeah, I'm happy to pass over to the board secretary to make any comments.
So just really briefly, Chair. So since the last board, the corporate risks have been presented to the committees and they've been reviewed in detail by the relevant committees that they're aligned to. So just to call out really that we've got 12 now risks remaining, 2 new, and 11 of the risks that the board would have seen at the last board meeting have now been de-escalated or closed, and the rationale is detailed in the paper as to why they've been closed. There's 2 increasing risks and 8 with no change, and just to really call the 2 risks which are in relation to respiratory and RSV, which have been discussed with the board and the committees, and obviously what's been discussed all morning about insufficient workforce to deliver. The 2 increased risks, again, of what you've seen through the board papers today in relation to planned care and increased delivery of the integrated community and acute scheduled care services. So just happy, well, to take any questions or individual questions to execs, but we have reviewed these in detail at the committee's chair.
Excellent, thanks Jo. Are there any questions in relation to this? I know Winston made a comment at the IM's meeting that perhaps it may assist in considering the BAF framework as we move this further up the agenda, so we're happy to consider that. Many thanks, and thank you Jo, and thank you team. It's an important piece of work and it's not just a paper exercise, so many thanks. Okay, we next go on to the integrated performance assurance report. Hugh.
Cadeirydd, diolch yn fawr. I won't repeat many of the comments that have already been made. I'm conscious the Chief Executive, Andrew and Jill have already commented on many of the aspects of the performance report, and just to reflect that the report in its entirety doesn't make for a comfortable document and demonstrates an organisation that's under unprecedented pressure at the moment. Chair, I won't either go into each measure. I'm sure there'll be questions that come up on those. But I'm conscious that behind each of these measures, there is a family that is affected, is a personal story for a patient, and indeed reflects the pressures that our colleagues are under. Instead of doing that, I just want to go into, I guess, highlighting the 5 key themes which are broadly driving the information that's in front of us. The first one, self-evidently, is an increase in demand that we're seeing, especially in ambulance red calls, and then in cancer and radiology and diagnostics and mental health. And, you know, in cancer alone, we're seeing 15% more cancer referrals from primary care than pre-pandemic, and 30% increase in diagnostic demand for cancer patients. So that's a key driver. The second one then is patient acuity. And in measuring patient acuity on a scale of 1 to 5, we've gone from, in October 2019, 19% of our inpatients being at level 4 or 5 at the higher end of acuity. Now we're at 32%. Now that's a significant growth that we're seeing in that space. The next item to highlight then is around kind of our space to treat and the challenges we have with our estate and with our bed capacity. And we're now regularly at 98% plus in terms of our occupancy rate, which clearly demonstrates a system in challenge. Then we've got discharge of patients. And if I just take a snapshot of a position in November, so 17th of November, we had 215 patients who were medically optimised and 100 patients who were ready to leave, which clearly has a knock-on impact then on our occupancy and on the system flow as a whole. And then lastly, just to highlight staff shortages and issues with which I know are well rehearsed in terms of our vacancies that we're carrying, the sickness rates that we're seeing, and those who are isolating, which again gives pressure into the remainder of the system. So, Chair, those are the 5 broad themes that I wanted to bring to the board's attention, and I'm sure that colleagues will have questions on the detail.
Thank you. That's really, really helpful to give that overview. I think I'd add to that as well the reduction in capacity because of social distancing and the green and red pathways, because I think we're doing 70% of the work that we would normally do if we didn't have COVID out in the community and in our hospitals. But thank you for that. That's really helpful. Judith.
Yeah, thank you. Yeah, my question is on a bit of the detail. It's on page 17, and there's apologies, my family controls just dropped out again. But there's reference to the accommodation issues in respect of the neurodevelopmental and psychological services. I know I keep raising this issue, but there's nothing about any timescales, because I do know that there have been some delays caused to recruitment because we don't have places for people to be based. So I just wondered if there was a timescale on the reviews of the accommodation, maybe not a total solution within a set period of time, but anything, sort of any pipeline.
So if I don't mind taking that, Chair, if that's okay. So yeah, I think the estates team and the directorate are working. So there's a number of actions really around accommodation, because accommodation, as we talked about for mental health, is a particular challenge. It's not been helped by some short-term issues we've had in some of the estate as well. So, for example, we've had some difficulties with the roof and ceiling in Brokerwin. All of those remedial works will be complete by January, and there'll be a bit of partial refurbishment of that in terms of flooring and painting as well to make that a better environment. So that'll be back available to the team from January, which in the short term it is a positive, but we recognise longer term probably that as an environment isn't appropriate for what we're trying to achieve. So there is a task and finish group that are reviewing new building options and opportunities for the entirety of the service. Some of those looking at the short-term opportunities we've had, and interestingly, some of the sites that we were discussing earlier on in relation to, I think, the agile working item and alternatives that there might be in the local area. So, for example, the Welsh Government buildings are all buildings that have been explored by the team over the course of the pandemic. So far, some of the discussions on those and the costs or rental costs around those have been prohibitive for us to enter a contract, but we'll continue to review and revisit those. There are also, obviously, with the Glean House issue, that would free up Tudor House again, which the mental health team gave over for the command centre. And there are conversations as well around how we what brief with the service around the spec and brief for Bro-Merthing as well, to bring that into different space for service delivery. I need to, what I'll do, Judith, is I haven't got a timeline on the outcome of that task and finish group work for the new building options, so I will firm that up and I will respond to you outside of the meeting if that's okay, and I'm happy to share that with other board members. I think the other final point I just wanted to add is we have been through this year trying to explore opportunities to replace the Preseli unit in Withybush by trying to utilise some revenue and change it, and that's proved difficult in terms of the Welsh Government position on that. However, we have that issue, and the replacement of Preseli has now made it into the capital discussions that we have with Welsh Government. It's a long way from saying it's approved and they're going to support it, but it is going to be a regular standing item on the agenda. So at least that will have some oversight and some and will be highlighted, and is something the team can now work with our estates team and a planning team on progressing as well. So I think that's a positive in the last week. That has been a bit of a frustration, I know, to the directorate.
Great, thanks. I didn't realise that a visit by myself and Elith would have so much progress so quickly to Preseli, but I think that whole area for community child health facilities is yeah, it's an interesting site, so I really welcome that update. Thank you.
Thank you. John.
Thank you, Chair. Can I refer to page 14, which notes the current performance around endoscopy? Now, I think as a board this morning, we've heard a number of interventions that we're taking as a board to try and manage the planned care waits. But in terms of endoscopy, the paper there just says that we are continuing to explore opportunities for additional capacity. And I think I'm right in saying that we've read this at previous boards. I am aware, and I'm sure the board is aware, that the issue of COVID and the requirements for additional PPE does affect throughput and capacity. I guess my question is, what are we doing in order to address the issue of over 1,277 patients waiting over 8 weeks for endoscopy, accepting what we've been told before are the challenges, please?
Again, happy to come in on that, Chair, if that's okay. So thanks, John. Firstly, recognise that obviously the 1,277 patients waiting is not where we want to be, and it's something we want to obviously improve, and the team have been working hard to bring that number down. I think it's also probably worth reflecting that in recent discussions nationally through the National Endoscopy Programme, the work we've done so far in Hywel Dda around endoscopy and recovery has actually been recognised as being leading or amongst the leading response in Wales. So relatively to Wales, we are getting traction with that plan, and we are probably doing better than some others. That doesn't mean that's what our ambition. I don't just want to be a little bit better than others. I do want to get to the level of performance that you're articulating. We have looked at opportunities, and this is a wider issue that we've been exploring anyway, around theatre capacity with private or independent sector providers, because who, as we know, as the report kind of has outlined, or a couple of the reports today outline, there are issues that they're having with workforce as well and being able to provide capacity. We have explored opportunities for us to take staff to some of those providers to use their facilities and rent their facilities, but so far they've rejected that offer from us because they can't guarantee the consistency of sessions that we would be looking for, and they feel it would compromise some of their private activity capacity at the moment. So that's something we're still working on. I think the final piece on this is we are also aware that there are opportunities. If we could do something regionally working with the National Endoscopy Programme, there are potential opportunities for endoscopy capacity increase that could be deliverable within quite a short time frame, and we are following our conversation. We had a couple of conversations in the last week with Swansea Bay around this, and we will be looking to take forward a regional discussion over the next few weeks that explores with the National Endoscopy Programme whether in South West Wales we could be the first area to develop a regional plan for a regional endoscopy multi-suite facility that could support the recovery across South West Wales. So that's all very, very new in the last week or two, and as I think Steve indicated earlier, a lot of things are moving very fast at the moment, and it's about trying to exploit opportunities as they arrive. And we will obviously continue to look at how we can increase our core capacity as well, and we are doing as well, if not better, than most of Wales in terms of reinstating our own endoscopy capacity to as close to pre-COVID levels as we can reach.
I could just sorry, John, I was just going to say, if you could bring Steve in to supplement that as well.
Just to add, and Andrew's giving you a sense of the speed with which this is going. Andrew and I discussed this, I think it was last week, Andrew, wasn't it, about the emerging solution. Firstly to say, my challenge back was, can we get down to 0 weights rather than 8-week weights by doing this? We might as well try and, because we know how important endoscopy is to early parts of the diagnosis pathway for people. And trying to build that in, maintaining choice on each of our sites as well, which the team are looking at now to ensure that if there was some sort of regional solution, clearly there would be some challenges around travel. Andrew's looking at that. We'll need to give some really careful thought to that, but our ambition. And in relation to Swansea Bay, really keen to work with them on this, because we think a joint workforce model would really help to make this happen quickly and robustly. However, I asked Andrew whether, in the absence of that, we can do it on our own, because I don't want to be held up, really.
John, would you like to come back?
Yeah, thank you, Chair. That is helpful, Andrew, and hopefully we will see some positive trajectory then in change, perhaps at the next board. Can I ask a question then, that in terms of the agenda under 4.9, I think it is, we've got a paper on the modular solution in terms of recovery. Are there any possibilities that may provide us additional capacity for an endoscopy, or is it primarily a workforce issue and therefore additional space is not merely the solution?
I would say, John, that the answer is it's a combination of those two things. So it's a mixture of additional workforce and space, because of the IPC guidelines we've got to operate, which reduce the productivity we can have through our core capacity. So we're obviously looking at all the opportunities to use more of our core capacity throughout the week. The modular facility won't necessarily directly support endoscopy because it's a day unit facility. We did explore putting 2 endoscopy theatres into that, but the scale of that just got too large and too big to make that feasible.
Okay, so I wonder whether that should be reconsidered in light of the trajectory of the graph. I'm not saying we should do it, but it might be useful to revisit it. Chair, can I just make one further comment also, again for board assurance, and that's in relation to the performance around the PADR, the appraisal system. That was discussed in detail at the People and the OD Committee. And Lisa and her team have been charged to look at ways in which that performance can be improved. I can't remember the date, but we are expecting a paper back at People Committee, whereby hopefully we will see a little bit more of a positive trajectory of performance with regards to the personal appraisal. Thank you.
Many thanks, John. Are there any other questions? They've been responded to, yeah. Thanks for the questions, Paul, and thanks for the response you in the chat bar. I just wondered if briefly we could have, as a board, a taste of the actuality out there at the moment, because when you see over 12 hours or a certain time waiting in an ambulance, it doesn't actually tell us the average or the most extreme. So I just wonder if you could briefly, Andrew, tell us, you know, what's the longest somebody has waited over 12 hours, and what's the longest somebody's waited on the back of one of the ambulances that's come to one of our hospitals since the last board meeting? And is this common, or is this, you know, an exception? And I'm really pleased what we're doing to enhance the A&E environment at the moment. Andrew.
Thanks, Chair. And yeah, it's worth reflecting that October has been the worst month across Wales for handover delays and lost hours in the system since we've started collecting that information, and it was around 50% higher than the previous worst month. So I think in terms of lost hours, the worst month has been across Wales 12 to 13,000 hours, and in October it reached 18,500 hours. And I think certainly a third of the way into November nationally, Wales was on track to surpass the 18,000 even in November because of the pressures being seen in the system. For us in Hywel Dda, we've seen obviously, as we've described, we've certainly seen some of those delays. The longest delay we've had in Hywel Dda was in Glangwili for an ambulance handover, and that was just over 15 hours. I would want to stress that whilst we wouldn't want anybody to wait on the back of an ambulance in an ideal situation for 15 hours, on that day where that longest wait happened, that didn't mean in those 15 hours nobody else was being offloaded or nobody else was being admitted or receiving care. That wasn't the delay in access to the emergency service on that day. There were 5 other ambulances offloaded in that time, and it more reflected the clinical priority and urgency of the patients coming through, both through ambulance services and also who were walking in off the street and self-presenting. So doesn't excuse the wait, and I think one of the conversations we've been having at a national level as chief operating officers and a peer group and with the national team is where we look to draw some red lines on, if you like, on what the maximum wait would be prepared to tolerate is, and certainly that's something that I think will be coming in the system. In terms of then delays in ED, they've regularly, or we've seen across the sites, waits of at least 3 to 4 days at times of patients in beds in ED awaiting admission, and the longest we've seen was just under 5.5 days in Bwrdd in October. There were some specific extenuating circumstances around that patient in that they were an oncology patient and required a side room, and because of some of the other patients it was deemed by the site and the clinical team that the safest place to keep them for that period was in a side room in ED. But that doesn't negate the fact that we are seeing in our sort of what would be our short stay assessment facilities and units for turning people around quickly, and in our ED we are seeing people waiting far longer than we would want to. And I can only apologise for that, but try and reassure that in the circuit, the circumstances are extremely difficult. The staff are doing their absolute best in some really difficult circumstances to provide the best care they can. They know at times they can't reach that standard, and that's where they themselves get frustrated, because that's not how they want to see themselves, the services they want to see themselves providing, and we'll continue to work with all the sites and the teams to try and support the improvement effort to see whatever we can do to mitigate, as we talked earlier on about the experience, or in terms of the environment, to make that a little better. We will do everything we can to do that.
Thank you, Andrew. And it's really important the way you open this paper to outline, you know, the top 5 or 6 pressures and why this is happening. And on behalf of the board, I'd like to apologise to those patients who have waited far too long, both in our A&Es for beds and also on the back of ambulances. And we are doing everything we can. And as Mandy said, every single, you know, this is about individual people and their families and their experience. And it will continue to be difficult, but we'll do everything we can to make it as comfortable and as safe as possible. But a massive thank you on behalf, apologies on behalf of us all. If I could just pick up a couple of other things in the performance report, please. Is there any reason, I'll go through them, there are not many, but is there any reason why there is a special cause variation in pressure sores, which is above the upper process limit? And is the PTAS fully up and running? It's great to see the ophthalmology, that's very encouraging. And the rollout C on symptom and patient initiated follow-up and outpatients, is this being scaled up quickly enough in your opinion? And the tertiary delays with people with, it's mentioned in the report, one of the issues, lung cancer, and being escalated. Does it make a difference when we escalate it? Is there more that we need to do?
Shall I start, Chair, by answering the question around the special cause variation around pressure damage? We've got a situation where we do scrutinise on a regular basis across every site the level of pressure damage that is being reported. I believe that the figures presented are invalidated. Nevertheless, what we are seeing, and we've referenced acuity earlier, is we're seeing people who are frail, who are coming into our services with pressure damage. And that's against a backdrop of a resource that we're looking at in our tissue viability services to strengthen, if at all possible, as we go forward, so we can make sure the expert advice and resources available in the community, in hospitals, and indeed wherever patients presenting with that need are cared for.
Thank you, Mandy. Andrew?
Yeah, I mean, I know Jill's joined, so I'll let Jill pick up the PTAS issue on that basis. In terms of the SOS and PVU, I think, so that's patient initiated follow-up, sorry, I didn't mean to use the abbreviation. We've seen a steady improvement in recent months. We know the target from Welsh Government is 20% of people to be on one of those pathways. Our current performance is 7.7%. It was only 6% the month before, so there has been some improvement. I think we're seeing some benefits of that in the context of only 5% of the patients that we've put on the list that we have put on have then come back to a consultant clinical pathway. So that implies for 95% of the people we're selecting, we're doing that appropriately, and they're in the, it's an appropriate means of managing them. I think other health boards that have done or are doing better at this than us at the moment have taken a blanket approach of moving everybody that's been waiting over 2 years for a follow-up onto one of these two pathways. And I know the team are looking at that, but exploring with our clinical teams the clinical governance concerns that some of the clinicians have around just a blanket move like that without a more managed transfer. And just in terms of numbers, in October, there were 628 new patients added to the SOS list and 336 the PVU list. So it is being utilised in all specialties now, and we would expect and hope to see that improvement continue through the rest of the year. And we do still have the option of taking a more blanket approach if the clinical teams agree that that's appropriate after we've finished reviewing and considering that as an option.
Okay, and that to be scrutinised by one of our committees, probably Quasar, but please, just so that we see that, developing at pace, obviously subject to quality and safety. Jill?
Thank you. In terms of PTAS, yes, PTAS is up and running, not in the way we'd actually anticipated at first, because what we seek to provide is a remote service, but due to some firewall issues in terms of IT, we've not been able to operate that remotely. So actually our clinicians have been operating out of ambulance headquarters, so directly reviewing individuals on the stack with ambulance control, which has been actually incredibly good learning opportunity. So we would be promoting that for any new clinicians joining the system anyway. So we do have that system in place, and the clinicians are reviewing individuals on the stack that can be managed in a different way and therefore don't need to be conveyed by WAST to hospital.
Thanks, Jill. I think I'll come and have a visit as well, if I may, just to see how it is. Okay, any other questions on the integrated performance report? Thank you so much. It just shows the massive pressure that everyone is under, and also the impact it's having on patients both within our hospitals and waiting for treatment and in their homes, as Anna says in the chat bar. So is everyone happy to accept the recommendation? Many thanks. We're going to go on now, please, to the financial report.
Diolch Cadeirydd. Just a couple of things to highlight here, and if I start off just by looking at our expenditure trend, agency spend is clearly a pressure and an issue for us, which has been throughout this year on nursing staff in particular. For the first year in our history, actually, nursing agency and medical agency are broadly at the same level in terms of financial spend. And historically, our medical agency was much higher than our nursing agency spend. And with both of those, both are at their highest ever level in the last month that we've seen, which demonstrates the workforce challenges we have as an organisation. Just in terms of a look forward, we have, since the last board meeting, had further funding through from Welsh Government for recovery funding, and we are currently working through how much of that we are able to utilise as a board, and therefore how much of that will we need to hand back to Welsh Government. Now that's a conversation that's ongoing at this stage, and we'll have a further discussion later on. But assuming that we work through that in a reasonable way over the next week or so, we are broadly on target then to deliver our 25 million deficit for the end of this year. And it's an important point to get to, that we deliver in line with the promises that we make at the start of the year. It builds on our credibility as an organisation to deliver against our plans. But just wanted to highlight that there is an issue that we're working through and will require an accountable officer letter in response to Welsh Government. One thing then just to bring to your attention, which impacts on our future years, is our savings delivery. Clearly last year we were challenged in the savings that we delivered, and we didn't deliver recurrent savings last year. This year we will deliver about 4.6 million of the 16.1 million savings requirement we had in our plan. Now that just builds an underlying deficit challenge for us as we go into the next planning round, and is one that I've brought to the board's attention before, remains a concern, and we'll be working through it with Welsh Government in line with the allocation of funding that will come through as a result of the Welsh Government's agreed budget. So we'll work on that and bring something back to a future board meeting. With that, Chair, happy to open for questions.
Many thanks, Hugh. Winston?
Thank you, Chair. Thank you, Hugh, for a really clear report, actually. Just on observations and followed by a question. I think as a finance position, we're making good progress as a board. I think some acknowledgement on the resources that we've been able to secure from Welsh Government is well met, because we've managed to secure resources for COVID-19 funding and also for the recovery. I think bizarrely we're now in a position where we were worrying about whether we'd actually achieve a 25 million deficit. Now we're worried that we're going to have to hand money back to Welsh Government. To get to that position has meant, I think, that our financial controls are quite robust, actually. So acknowledge not only here in this team, but also the operational teams as well. But I think the thing that I want to highlight, which is in the report, is this bit about savings and our ability to actually secure long-term savings. And my reading of the report, and hopefully Hugh, you'll be able to correct and enlighten the board, is that we've not got a problem actually identifying the savings, but I think our challenge or hurdle might be in actually those savings actually translate them into reality, into actual sustainable savings. And I just want to hear from Hugh and the team what those hurdles might be and what we could reasonably do, not immediately, but in the long term towards addressing that. I'm just wondering, is it a cultural thing, is it a capacity thing, or is it something else that we need to be doing differently?
Yeah, thank you. I think the fundamental issue that we have as an organisation, that we've just spoken about the pressures that we have operationally, and that clearly has an impact not only on our ability to deliver savings, but also on our staff, our managers, who are focused on delivering in the here and now, and not always able to kind of look forward at what might be possible in the future. So there's a double impact there. There are opportunities, but I can't say at this stage that I've fully identified opportunities for savings for this year or next year in terms of the full value. That is clearly a challenge as we're coming out of a very uncertain period and going into quite an uncertain period. I hope that over the next few months, as we get clarity on our funding allocation, that we'll be able to start to land some of the challenges we have. And just maybe to conclude, you know, if I distill our challenges into two categories, we've got some very clear demand side challenges on our services that have been alluded to before in the performance report. We've got some very clear supply side challenges in terms of our ability to recruit and ability to retain staff. Those two things are where we will inevitably have to address if we're going to deliver financial sustainability over the next few years.
Thank you, Hugh. And if I could bring Andrew in as well, please.
Sorry, just trying to click all the buttons at the right moment. So, I mean, Hugh kind of touched on the final point that I was going to make, I think, actually just around the supply side challenge as much as anything. And I think one of the things we've reflected on as an exec team only this week is that the underlying challenge we've got around workforce, whether it's trying to recruit to the existing model or even making sure we've got a workforce or recruiting to a workforce that delivers the future model, is a significant challenge and potential barrier to us achieving what we want to achieve. Steve's outlined some of the conversation we've had on that earlier, but I think our reflection was because of that, we've maybe, in terms of some of the schemes we've tried to take forward, we've maybe gone with something and only managed to get 30–40% of the way there, so therefore never quite realised the full benefit. And you know, in simple terms, that basically leaves us left with one option of model delivery, which is the bed model and the bed position, and that becomes the default regardless, because we can't close our doors or not have people come through. So that is something I think we were discussing yesterday as an executive. I think that's something that through this planning round we need to try and get our take a slightly different view and approach on as we go forward to make sure that we've got a more robust assessment of what's going to be deliverable and what those impacts are actually going to be.
Thanks, Andrew. And I'm going to bring Stephen as well.
Yeah, just to add to that, I agree. Everything that Hugh and Andrew said, but sort of at another level to this. Before we went into COVID, we know we were broadly getting to technical efficiency levels that were comparable to Wales, which in itself, and there's always housekeeping you can do. There's always more you can do, but actually there was less and less to go at in the things that would have been more in the traditional savings pot for us. COVID, of course, has pushed some of that back even further because of the IP&C and all of those productivity losses. But I think that the wider issue for us is that we are increasingly moving into the structural and allocated efficiency world, which is by its nature quite difficult to do, because it is about the health-seeking behaviour of our public, the health inequalities that we've talked about today, but also the building of a new hospital to deal with some of our underlying structural challenges of running so many services on so many small sites. So it's not to get us off the hook at all, Winston, because we know we've got to keep going with it. Some of those planning objectives, particularly those that are linked to the roadmap, are all contributing to this. You know, the design assumption planning objective, and the new hospital. But we've got to keep going with the housekeeping and with those longer term things. And of course, that links into our discussion with Welsh Government about the approvability of our IM2P, because we'll need to, as well as getting the board to the point where you are confident that we've got the right plan, we also need to do the same for Welsh Government.
Thank you. Thank you, everyone.
Yeah, thank you. That's great.
Thanks, Winston. Board happy to accept the recommendation. Many thanks to you. If we go on to the next item on the agenda, it's the government's arrangements to manage the allocation of recovery funding, bearing in mind that a lot of decisions have to be made very quickly at this moment in time. So this paper is to keep us safe. Yeah. I think the board has read the paper. Andrew, do you want to add any comments to it?
I think just briefly, firstly, I think obviously because we've subsequently and very late, and apologies for that, put in the additional paper as well around an update on the procurement option for the modular unit. Probably this paper is more, in terms of consideration, is more confined to the first part, which is around the governance arrangements changes, and we're really asking the board to approve the recovery plan in totality, even recognising that the quantum of projected spend has been revised down due to the limited availability of independent sector capacity. Ultimately, we think, from the perspective of Welsh Government, we've put in bids and submissions against their recovery monies, and said what it's for. So they've, by default, in allocating the money, indicated the support for us using the independent sector to deliver this plan. And the purpose of putting forward this suggestion around a revised arrangement for the governance process for this was to ensure that that we maintain good governance as a board, but also enabled us to be as agile as we possibly can in operational delivery terms to make sure we don't miss any opportunities as they arise, because as we've touched on a few times, things are happening very quickly and some of those opportunities diminish quite quickly if we can't respond. So it's trying to keep us safe, as you said, as well as give us the maximum opportunity to improve the service position and address some of the challenges our population are facing in terms of access to services at the moment.
Many thanks, Andrew. And I think Maynard has a question.
Thank you, Chair. Yeah, it's just a very quick one in terms of third-party contracts mentioned on page 4. Just want to ensure that we are putting quality measures in there as part of that contract, and ask how any deficiencies in that area will be reported to board.
Yes, so the intention is that the overall delivery of the plans will be obviously monitored and tracked through the Sustainable Resource Committee for complete openness and transparency. We may want a conversation around, I don't know, Chair, around whether we would take anything that and I'm sure we would anyway, if we identified quality and safety concerns around the delivery of any of those contracts. I'm sure we would raise those through the CRESAC committee anyway, as we do with other kind of commissioned activity and tertiary service activity we commission. But just to reassure Maynard that within the contract, I'm conscious it's probably not pulled out well enough in the paper, but I'm happy to share with you a schedule of the kind of metrics and KPIs that we expect the provider to report to us on, and there is a very full and long list of patient experience and quality and safety metrics and indicators within that schedule.
Thanks very much, Andrew.
And Mandy's also responded in the message bar, Maynard, so thank you, Mandy. Are there any other questions in respect to the governance arrangements and indeed the recovery plan? Okay, thank you. The board's happy to endorse and ratify the governance approach to allow executive sign-off to the expenditure linked to the recovery monies and delegate authority to the lead executive director to execute the appropriate contract arrangements for the modular solution. Many thanks, everybody. If we get the next paper is 4.9, the utilisation of recovery funding.
I think that was a verbal.
Yeah, that was it. Okay.
Which I think we've lightly touched on, but you might want to add a few overarching comments. It's against the environment that we're in.
Yeah, Chair, there's nothing to add to what I've said in the finance section. We're in ongoing discussion with Welsh Government on the implications of handing back any recovery funding that we aren't able to utilise this year, and we'll have a further discussion later on in committee.
I would just record my thanks to Hugh and the team who worked very closely with Welsh Government on this, and I do think probably being able to be clearer with them than maybe true in other areas. So I think that's, again, partly down to the speed we've been doing it. It is a testament to the work of our finance team that they've been able to keep ourselves alongside Welsh Government.
Excellent, well done, thank you.
I just thought, Chair, in terms of openness and transparency, the discussion is in committee, even though it's noticed on the public agenda, that's because the plans are still in process and draft at this point, and then it will come formally back through the public board, Chair.
Super, so the public will be able to see.
Absolutely, Chair.
That's grand, thank you. Shall I go on to the modular solution there?
Right, thank you, Chair. In terms of this one, just a couple of comments, because I'm hoping and think the paper is relatively self-explanatory. Just to firstly apologise for the late sharing of the paper. It's because opportunity emerged really only in the last 10 days that we felt we needed to try and explore and didn't want to miss out on. Just to reflect, just 3 or 4 points then. Firstly, it's important to note the modular solution has been designed and signed off by our clinical and operational leads, so it's been through their engagement and their thoughts that we've put together the proposal around that we have. The paper highlights a number of risks, but most notably the ability to achieve in Q4, although we think with the conversations we've had and the establishment of a weekly project team and some legal options we've got around vesting, we can mitigate those risks and ensure delivery by the end of Q4. And just on the workforce part of that, which is an element of the plan as well, there are options. There is a full recruitment programme kicking off on Monday to help support and reinforce our day surgical unit teams, and the team there have been very enthusiastic about engaging in that. But there is an insourcing opportunity that we could turn to if that didn't bear fruit, that would help provide the workforce. And finally, I think the other point I just wanted to make, just a flag, was obviously the opportunity to purchase the unit as opposed to lease it gives us an asset that we can potentially use for up to 30 years, and the relative cost difference is only £2 million between purchasing and the lease cost over the original proposal, which was a lease of 3 years. So I think in that context it does represent good value for money, and obviously gives us an opportunity next year with some of the recurrent monies we've got that would have been badged against the lease cost to do more in terms of the activity space as well, and treatment space. So I think there's a couple of benefits from taking this approach, even recognising that it's still a substantial sum of capital that we've brought forward at quite short notice.
Thanks, Andrew. Excellent. Could I just ask you, is it possible to revisit endoscopy in the solution as John raised before? I know there's a lot of work already gone on.
I mean, I think in terms of where we've got to, that's probably very difficult because we've got a design, and on approval we would be looking to start the works very quickly. So I think that we may have missed the opportunity on the design side for the modular unit, but there is certainly things we can look at around how we use the space that's vacated in Prince Philip to maybe provide a bit more core capacity within our own sites, and other opportunities around our sites to explore the endoscopy answer and solution as well. And I know, talking to Lee, he's got some ideas potentially around the medium term as well that we could look at. So there's a few options around endoscopy that we can explore.
Okay, thank you. And as Paul said, it's an excellent explanation, Andrew, on the benefits and the merits of this opportunity. Are the board happy to endorse and approve it? And we note the risks and mitigation. Many thanks and well done. And where would the endoscopy be reported to? The other solutions in relation to that going forward?
The additional capacity. We bring it to execs. It's a very live discussion at the moment. I'm aware there's a number of opportunities. It'll come to execs, and once we've got a plan, we'll then bring it to board first, and then it can
That's grand. Thank you very much. Next is the haematology contractor board.
Thank you, Chair. It's me again. Sorry, you'll get bored of my voice soon. So this is a proposal from haematology. I first became aware of it actually when I was turnaround director, because it was being explored in terms of the potential financial benefits of taking on a managed or awarding a managed service provider contract. So the paper seeking that we recommend approval to award the managed service agreement for haematology and coagulation equipment, reagent and consumables. The service, just in terms of context, have implemented an integrated blood service strategy, which sees the service delivered as a network across the 4 sites, and so fundamental to that being effective and efficient will be the managed service contract almost becomes a central requirement for that, and that will enable workflow and the standardization of equipment and analytical capability. The pathology team have already successfully implemented similar arrangements around both clinical biochemistry and blood transfusion, and have realised we've seen the benefits of those realised. So I hope that would give some confidence and assurance to the board that the benefits that the arrangement we suggest will deliver, we're confident in being able to realise those. And obviously, if we were to support that today, we would then need to go to Welsh Government to seek approval because of the value, because the value is above £1 million.
Many thanks, Andrew. Maynard, quick question.
Very quick question, Andrew. It mentions that there's IT solution involved in this. Just want to make sure that that IT element of it will integrate with our existing systems such as LIMS, Welsh PAS and the clinical portal.
Yeah, I understand that would have been as part of the specification, but I don't know whether Hugh specifically from an IT perspective can answer that technically better than me.
The team are fully engaged.
Grant, thank you. So is the board happy to approve? Many thanks. Next item on the agenda is the Strategic Enabling Group update.
Chair, thank you. I've got nothing to add to the report. It's a very brief report. We spoke about social value at the last meeting, and we've already had that discussion this morning with Joe's report on behalf of Ros. As won't be a surprise, Chair, given the membership of the group, we had a very good, robust discussion and a thorough going over of the issue, and I think it's really helped us start to form or formulate our strategy, which we'll bring back to the board in this space. Thank you.
Many thanks, Hugh. The board's happy to receive the report. Super, thank you. Now go into the assurance section. It's the report of the planning committee, which is an easier name. Yeah, Maynard.
Thank you, Chair. Nothing to add to the paper. There are 3 items mentioned for the board's attention, 2 of which have already been mentioned today, just to keep the board's attention on the women's and children's phase 2 work, and there are still some concerns in that area.
Thank you. Could I seek assurance in respect of the plan for the 75% of children who are waiting over 26 weeks for a mental health assessment? That's half a year in a child's life. It's an awful long time, and I just wondered whether when we come back with the recovery plan for mental health, we could also bring that back as well. What mental health intend to do.
Andrew, do you want to pick that up?
Yeah, I wasn't sure if you wanted me to come in. Sorry, I was waiting. Just didn't want to jump in. Yes, happy to bring that. Just quickly, one of the things I've asked the team to consider, and they're working through now, is a bit like we've done with scheduled care. Is we probably haven't so far really explored the opportunities of the independent sector and outsourcing market to see how we can address some of those waiting times, not just clear the backlogs, but also get us to a level of performance over the next 2 or 3 years that meets the targets. That's wider than just the CAMS issue. That would be for all of the mental health waiting lists that we know we've got issues, and we picked up were flagged in the performance report earlier on today. So I know members of the directorate are meeting with, I think, Sean supporting that, and finance colleagues to develop a similar kind of expression of interest to go out to the market for a plan over the next 3 years to support recovery and delivery of those services, whilst we look to build our own service that's sustainable internally with a kind of tapering effect over the course of the 3 years. So that's something that they're working on well as we speak, really.
Thank you, Andrew. And again, will that go back to the planning committee?
It'll come to the board and then the committee.
Okay, that's grand. Many thanks. John?
Chair, can I ask a question in relation to the Women and Children's Phase 2 project? If my memory serves me correctly, we've had increasing costs with this particular project recently, 300k, I think, in terms of remedial work for floors. This report now talks about an additional sum of money of 200k associated with cladding, I think it says, or for the building. I'm a bit concerned that this project is increasingly, at each report we get, associated with increasing costs for whatever reasons.
The committee would agree with you, John, hence the reason it's in the items of concern to raise to the board. It is one of those projects that just seems to keep giving in a bad way.
Andrew, would you like to come in?
Only to say that as I sit here, John, I don't have a detailed answer I can give you on that or the reasons for that, but I can to hand, but I can sort that out and share that with you outside of the meeting, just in terms of what's happened in that latest update.
I'm going to bring in Steve as well.
And I think that I recall previous board meetings we discussed the sort of the systematic concerns that might be coming out of this this business case and the way it was the way it has evolved, as Professor Gallman said, and Louis was undertaking a bit of a review, lessons learned of it, to ensure that we then can approach the building of a big hospital with the benefit of the lessons that certainly need to be learned from this project. So I think probably need to bring that lessons learned back at some point. I don't think we've seen that at board yet.
Yeah, Chair, we've seen the draft in audit committee, and the audit chair asked for the management response to come back to the December committee. So if we take it there, we could then append it to our report to January board, if that's okay.
Yeah. So that might deal with some of John's more systematic.
Yeah, thank you. And that specific question, I'm sure Andrew could get the details for you to know offline, John.
Yeah, that's right. Yeah, thank you.
Well, thank you. Okay, thank you very much. If I can now go on to the Health and Safety Committee, Judith.
Missed people, Chair.
I missed people. Sorry, the most important thing is how organisation are people. Excuse me, John.
The most important committee, Chair.
Aye.
Our people.
John.
Okay. Thank you, Chair. So this presents the report then of the People and OD and Culture Committee. Two things to note from the report. I'm keen as committee chair that as an organisation we are ambitious with regards to our Welsh language provision, and the committee have certainly been challenging our colleagues and teams in order to be ambitious with regards to our bilingual skills policy as well as our Welsh language provision, and there's some note on that, and we're expecting some further reports back to the committee. There's nothing else that I would wish to note other than to ask the board to approve the revised terms of reference which are attached and the additional elements which are noted in red, please, Chair.
Many thanks, John. Judith, would you like to ask a question? Judith, I'm waiting for your next. She's waiting for health and safety. I think.
Just to mention, I want to remind the board that certain members of the Transformation Steering Group are also looking at opportunities around Welsh language and culture and what we can do in terms of generating planning objectives to go beyond the standards. I know it's dropped off the agenda a little for all sorts of reasons, but that work is, I think, going on in the background, John. So we'll be able to bring something back to board when TSG has that debate.
Super. Many thanks.
Thank you.
And the board's happy to approve the new terms of, or the amended terms of reference for the People Committee. That's grand. Diolch yn fawr, John. Yes. If I go on now to the Health and Safety Committee, Judith.
Thank you, Chair. The report from the meeting is there for information. I would like to, however, with pleasure, highlight the fact that all of the Health and Safety Executive enforcement notices have now been lifted, so I can hear the sigh of relief from the Chief Executive. I would like to say, in all seriousness, a huge thank you to the Health and Safety team and to Mandy's leadership of that team. The committee have noted how they've developed over time, and it really is down to their hard work and liaison with the Health and Safety Inspector, and also the work of all our managers who now really have taken on board the requirements of their role in respect of health and safety and seen it very much as part of the way services are managed, the way staff are treated and the environment, and all of that has added to the recent lifting of those enforcement notices. the aim of the committee now and to support the team to make sure that we're proactive around health and safety. So rather than rating actions, and there have been subsequent ones that are either happened or on the cards, that we know what we're going to expect from the visit rather than have all of these enforcement notices again. We don't want to be in that place. So it's really great to be able to bring that to the board. And as been noted in the chat bar, really a special mention for Tim Harrison, who's led the health and safety team, but also, as I say, Mandy's leadership of the department. Thank you, Chair. Happy to take questions.
Thank you, Judith. I know Steve wants to come in.
Yeah, just briefly, Mandy will probably may want to say something as well, but we met informally with the lead from the Health and Safety Executive, was it yesterday or the day before, to get feedback before the final letter, and it has been a huge accomplishment. I would absolutely echo the leadership and passion that Mandy's brought to it, that Tim Harrison has led, but also for the committee itself. Judith, we had Anne with us as the deputy of the committee there, but the real sense of determination and drive that the committee has used. I did ask Helen, the health and safety executive lead, did she have a message that she would like me to convey to board today, knowing that we had our meeting this week? And she said the letter that is coming is really going to recognise just how far we've come as an organisation, and for her the change has been obvious. The cultural change, the change of behaviour, the enthusiasm with which people who she's talked to across the organisation now embrace health and safety issues. Clearly more work to do, there always is, but it was really great to hear from her just the sense of change that she'd felt in the organisation over the last 2 years.
Excellent. Thank you, Steve. Mandy, do you want to come in and bask in some of it?
No, it's been a pleasure, I think. I just wanted to echo some of the comments, and I'm very conscious of time. So Tim and the team have done an amazing job, and I think without them we wouldn't be in the place that we're in today. But as Judith indicated, this is a whole organisational effort, and I think that the work that's been put in by the general managers, the teams at every site in every service across the whole organisation has enabled the inspector to reflect upon the fact that she has seen a cultural shift in the understanding of individual roles and responsibilities. And I think given where we are now, we've moved from 0, we're now at base 1. And as I indicated in the Health and Safety Assurance Committee, this enables us now to give some headspace to the future and to proactively start really thinking about where we're going to go next. So Tim's already sort of taken a few days off in readiness to get started on the next focused pieces of work that we're going to take forward in the coming year. Thank you, everybody, though.
Thanks, Mandy. Huge thank you from the board to yourself, Tim, the team, the organisation and the committee. And it's wonderful to be in this place. Well done. Diolch. So next we're going to go to the report of the Sustainable Resources Committee. Winston.
Thank you, Chair. Thank you, Board. Yeah, we met on the 28th of October. I think the report speaks for itself. I'm just going to put out one or two things. First thing, we scrutinised a month 6 position, and that's where we highlighted that we were at a risk of undershooting our financial position rather than overshooting. We were really pleased to hear our sign up to the digital inclusion charter. We haven't got time to go through that in more detail, but we certainly look forward to having a board session or updating the board on what that actually means. And we reviewed our arrangements around cybersecurity. We covered a lot of other ground, but I'm going to pause for now because I'm aware of time, and if there are any questions.
Many thanks, Winston. Any questions on the report? No, thank you very much, Winston. It's very comprehensive. Diolch. So we're now going to go to the committee update reports. Does anybody wish to raise anything on these reports at all?
There were 2 matters, Chair, from the stakeholder reference group to raise the one matter to raise the board's attention, which is in the paper. Just didn't want to skirt over that. And obviously there were two issues to raise of risk in terms of GIRF, and again another SRG comment is an area of risk for the board. It's in the SBAR, but just to call them out.
Thank you. And I think the board will endorse what the stakeholder reference group has brought to our attention. We totally agree with that. So many thanks for that. And I might just go to the second S bar. So the board happy to endorse the updates and receive the report. Many thanks. And the next one is the working in partnership with the summary of the joint committees and the collaboratives.
Happy to take questions, Chair.
Any questions? No? Okay, happy to accept that. Thank you very much. Have I missed charitable funds out at all?
No, charitable fund is contained in the committee update, Chair.
Super, many thanks, that's great. And then the next one is the statutory partnerships update.
If I could just make 2 points, please, Chair.
Yes, please do, Jill.
Thank you. Just to reflect that at the last meeting we had a visit from the Children's Commissioner for Wales, just checking our progress on her report, No Wrong Door, which brings together children's services. And I just wanted to highlight that based on the fact that we have talked about the importance of children's services today in our meeting on several occasions. And then the second point I just wanted to reflect was that just to offer a huge thanks and recognition to Martin Palfreman, who was the regional head of collaboration for the Regional Partnership Board. He's been with the Regional Partnership Board since its inception and supported us through that journey of delivery to the point at which we've reached at this point. So a huge amount of work, sometimes unseen, but really worked in terms of not only local relationships, but that important relationship with Welsh Government, ministers and others. So just to offer our thanks as well from that perspective.
I'm sure that there's an official letter from the board to thank him for his services. Thank you. Are there any questions? Comments? Okay, many thanks. And then, sorry,
can I just come in on that? Yes, can I echo what Jill said about Martin Palfreman, but just to emphasise as well in respect of the visit from the Children's Commissioner. You'll see reference to an event whereby myself and Hazel will be questioned by children on a virtual panel about the work we're doing in the region. So I'm really looking forward to that taking place next week, and I will report back on how that goes. I'm hoping I'll be very ably supported by members of the regional children's group who've also been invited, but it is a question and answer session for the chairs.
Excellent. Judith, it will probably be one of the hardest scrutiny meetings you've ever had. But it'll be, I'm sure it'll be absolutely on the point and wonderful. I remember when I, many years ago, thinking about the year 2000, I was interviewed for Deputy Children's Commissioner, and it was a full children's panel, and it went on for quite a long time. And you realise that you have to be absolutely and utterly honest and be yourself. So I'm sure it'll be a real success. Thank you. Oh, Jennifer's priming them with questions. Oh dear. There we go. So the next item is for information, which is the CHC annual report. Can I thank the CHC for the annual report, which we'll look forward to discussing with them in our next meeting. And then the board annual work plan.
This chair for information, but we need to update it in light of some of the conversations in today's board, Chair.
Many thanks, Jo. Okay, so can I say that bring the meeting to an end? And many apologies, it's late, but I think that's a reflection on the amount of work that's actually going on at the moment, and it was important that we gave a lot of time to some of the very important subjects and papers in our board meeting. If I could give 5 more minutes break, and then we will meet again for our in-committee session. So diolch yn fawr, Bob, thank you very much. See you in 5 minutes. Thank you.